Morning, Anjana.
Good morning.
All good?
All good.
Quite a number of joined, huh? Not bad.
Yeah, we just started.
How many have registered, Anjana?
I haven't checked the number. People were registering till the last moment. I'll just check it and let you know.
Good morning, Brinda.
We'll start. Ask them to start.
We'll start, doctor. I think that's more better. 10 o'clock, we should start.
Yeah.
Good morning, everyone. It's my pleasure to welcome you all to ISPPD Basic Science Rapid Review Program, organized by Indian Society of Periodontics and Preventive Dentistry, hosted by Department of Pediatric and Preventive Dentistry, Royal Dental College, Chadisheri. We extend a warm welcome to all our respected speakers, faculty members, and dear participants. We hope today's sessions will be informative and academically enriching for everyone. Now, I would like to invite Dr. Anjana Ma'am, Head of the Department of Pediatric and Preventive Dentistry, Royal Dental College, and Executive Member of Indian Society of Periodontics and Preventive Dentistry, to deliver welcome note. Welcome you, ma'am.
Thank you, dear. Good morning, one and all. I would like to thank the Indian Society of Periodontics and Preventive Dentistry, the President, Dr. Sudhindra Balika, the Honorary Secretary, Dr. Varinder Goyal, and all the Executive Committee members for having given us this opportunity to host this program. I think this is the first time we are having a rapid review for the Basic Sciences exam. I welcome all the participants, the office bearers, and the speakers, the faculty members, to this program. I wish a very happy and informative session for all the students and a very good session for all the speakers as well. Welcome you all.
Thank you, ma'am. Now, I would like to invite Dr. Sudhindra Baliga M., President of ISPPD, for Presidential Address. Sir.
Good morning to all of you. On behalf of the Indian Society of Pediatric and Preventive Dentistry, it's my privilege to inaugurate this first Basic Science Rapid Review hosted by Department of Pediatric and Preventive Dentistry, Royal Dental College, under the leadership of Dr. Anjana. Indian Society of Pediatric and Preventive Dentistry does not leave any stone unturned when it comes to student-friendly activities. We are the first of the society who are introduced this rapid review for basic sciences. This was in contention that only exam-going students of the third year have to be having revision exercises for appearing for the 3 theory exams and the clinical exams. this exam also is very important with the perspective that we have seen that there has to be emphasis on basic sciences, which is the basic foundation when it comes to child oral health care. We have also seen that in recent days that students are not performing well in these exams in majority of the universities, and less emphasis, the whole focus has been on just passing these exams than gaining more marks. I feel I always believe that uh, qualification is not important, education is. So with this context, we had a series of curriculum revision workshop which was done under the aegis of the National Dental Commission. And there has been a lot of deliberation on what should be basic science for pediatric dentistry and vice versa, and for all the other super and specialty subjects in dentistry for both postgraduates and undergraduates. Because we have a word called applied aspects. And when it comes to applied aspects, we have to know what is important when it comes per se to pediatric and preventive dentistry. However, with all those deliberations in the National Dental Commission, with all the stakeholders, there are a lot of deliberations, but definitely it will take a year for the new curriculum for both undergraduation and postgraduates to come out, because as it needs to be notified. So my always intention, our intention from the society has been very clear: student friendly, academically oriented society, which works for the upliftment of this profession. We all know that you are all ending up, though there are opportunities in the academic platform, but now what we see is we have around approximately 800 odd seats in 325 dental colleges. All of you should know the basic science, applied aspects of it, and then start your practice. So make sure that you are because when it comes to pediatric dentistry, when it comes to child general health and child oral health, please lay emphasis, because there's a growing child and you need to know so many things which requires both to understand growth and development and per se to all the systems whichever are concerned in this basic science program which was being deliberated by the Dental Council of India as of date. So wishing the students all the best, as well as the organizers who have taken up all the efforts to make this program a success. I request all of you to attend all the lectures, stay attentive without any distractions, keep the mobile phones off. I know the average concentration time is less, but please stay attentive, be there for all the 2 days, and definitely this will be a fruitful workshop for you. Wishing you all the best. Thank you so much. Jai Hind.
Thank you. Sir.
Thank you, sir. With the blessings of Dr. Varinder Goyal, let's start our today's scientific session. Our first speaker for today is Dr. Nandita P. It's my privilege to introduce Dr. Nandita P., Assistant Professor in the Department of Anatomy at Amrita Institute of Medical Science, Kochi. She completed her MBBS from P.K. Das Institute of Medical Science and pursued her MG in Anatomy from Amrita School of Medical Science. She actively involved in digital anatomy education and academic research with multiple publications in reputed journals. Her areas of expertise include gross anatomy, embryology, and histology. We warmly welcome you, ma'am. Over to you, ma'am.
Sure. Question.
Good morning, ma'am. Am I audible?
Yes, ma'am, you are audible.
Hello?
Yeah, you can start your screen sharing.
Okay, ma'am. Ma'am, can you see my screen?
No?
Okay.
Yeah, now it is come.
Yeah, okay. Good morning. So today we'll be just revising the most or frequently asked questions from in the BDS curriculum. So we've referred mostly the KUHAS question papers and Rajiv Gandhi University question papers. So we'll be just discussing what is to be focused on the frequently asked questions. So here we have the most prominently asked question. One is the scalp. Then we have pharynx. The other one is larynx. Then we have parotid gland, tongue, facial nerve, TMJ, thyroid gland, cavernous sinus, internal capsule. So these are the most frequently, they've been repeated so many times. So these are the most frequently asked questions. Okay. So the first one is scalp. Now, you know what scalp is. There are different layers of the scalp. You know all that. So what is to be focused and what has been asked in the previous question papers? So mostly they have asked the layers of the scalp, the blood supply, nerve supply, and scalp and the applied aspects. So scalp is one region where every layer carries one or other what do I say, one or other clinical aspect. So it is that important. The scalp, as you can see here, there are different layers of the scalp. And I suggest you make a small note like this where everything can be involved, like all these, what I've added right now here, clinical pearls. So you can make a small note like that where everything can be revised within 5 minutes. So you know that there are different layers of the scalp. There is skin, as you can see here, there is skin. Then you have a connective tissue layer. You have an aponeurotic layer. Then there is loose areolar connective tissue layer. And finally, there is pericranium. So I'll be focusing what are the main applied anatomy which is related to all these layers. So when you talk about the skin of the skin has, you know that there is a lot of hair on the skin and then sebaceous gland. There are a lot of sebaceous glands. So because of the presence of increased sebaceous gland, because you know there should be sebum secretion because we have hair and it needs to be lubricated. I mean, it should be kept moist or oily. So we have a lot of sebaceous gland on the skin of the scalp. So these sebaceous gland, it is a bone as well as a brain. So when there are a lot of sebaceous gland, there is always a chance for sebaceous cysts. So sebaceous cysts are very common on the scalp. Okay, so that is one clinical anatomical aspect which is related to the skin of the scalp. Now, coming to the connective tissue layer, now this layer is very tough. It has dense fibrous connective tissue. And this is the layer where you find all the nerves and vessels which are supplying. So they come all the way from the periphery, they go to this layer, okay, to this, from the periphery, they go to the connective tissue layer. So that is very important. Now, this is the layer where the neurovascular structures are lying. So, you know that scalp is a very vascular, very vascular region. It has immense vascular supply. And you know that when you see the surface of the scalp, there is a lot of anastomosis happening. So it is actually an anastomosis between the external carotid artery and the internal carotid artery. So there is anastomosis of the carotid system completely. So this layer, when this layer is injured, when there is trauma to this layer, the scalp will bleed profusely. One reason is because this is one of the common questions asked. Why do the scalp bleed profusely? One reason is because the artery, immense arterial anastomosis, and there are too many arteries. And second is because it is an artery. So you know that blood is traveling in high pressure in an artery. So so what will happen? It will bleed profusely. Another thing is related to this layer, that is this connective tissue layer. It has dense fibrous tissue, and there are a lot of septas which are extending into this layer and is dividing the scalp into different lobules. And because of that, this, you know that in this vessels, the tunica adventitia of the vessels will be adherent to this connective tissue, because apparently because both of them are connective tissue. Now, because of this adherence, when there is an injury to the scalp, this would open up. That is, this vessel, they are closely adherent to this. When the scalp is injured, they cannot retract because of the presence of this, because of the fusion between the connective tissue of the vessel as well as the scalp. So that is one reason. Three reasons why scalp bleed profusely. One, because it has anonymous arterial supply. Two, because of this fibrous adhesion between the walls of the artery and the scalp. And third one, it is because it is artery. Because artery, the blood is flowing at high pressure. So these are the different reasons why the scalp bleed profusely. Then the next layer is the aponeurotic layer. So you know that in the scalp there are two muscles, isn't it? Occipitofrontal muscle is there. Both of them have two bellies each. So what happens is the occipital belly muscle has bony attachment. It is attached to the superior nuchal line. To the side, it has attached to the zygomatic arch. But the frontal belly, it is fusing with the skin of the forehead. So because of that, when there is an injury to the scalp, the blood, because one reason is the gravity, it is going to bleed, or it is going to gravitate into the eye, because it is attached, it is covered, or it is continuous with the skin of the face. So it will gravitate into the eyelid, and that is the reason for black eye. So that is another important applied anatomy which is related to the aponeurotic layer of the scalp. Then the next one is loose areolar tissue. Now, this layer is quite a dangerous layer, because in this layer we have the emissary vein, and you know that emissary vein, they are valvulus vein, and they actually connect the intracranial sinuses to extracranial sinuses. Now, because of this presence of emissary vein here, the infections which are present in the scalp can easily spread into the intracranial sinuses. So that is one of the other applied anatomy which is related to scalp. So I think we have covered mostly everything about the scalp. As you can see here, I have added some clinical pearls, which is profuse bleeding, scalp wound, the hematoma, emissary veins. And you know that sensation will be lost when because it has too many nerves applying it, 10 nerves applying it. So when there is an injury, there is a chance for loss of sensation. So these are the things that you should know. I mean, the concepts that I wanted to clear regarding the scalp when applied anatomy is asked. Other than that, you should know the layers of the scalp, the blood supply of the scalp, the importance of each layer, the nerve supply. Okay, so we have discussed all the applied anatomy part which is related to scalp. Now, we are moving on to the cavernous sinus. Now, you know that there are too many dural sinuses in the, inside the skull. There is superior sagittal, inferior sagittal, so many sinuses. But the most important of them all is the cavernous sinus. And this question has been repeatedly asked. All the things about cavernous sinus has been repeatedly asked. So this is very, 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 very important question, cavernous sinus. So this sinus, so you should know about the location of the cavernous sinus. Okay. And then it is the relations, the contents, tributaries, and the applied anatomy. So here I have a picture of the cavernous sinus. Now you can see this. These two are the cavernous sinus. So you should know about the relation. So this is the roof. There you'll have the optic chiasma. And then medially you will have the pituitary gland. So all these things you can, it is very easy to learn the relation. Now what I am concentrating will be on the applied anatomy. So knowing the relation is very, very, very important when you're learning about the applied anatomy of the cavernous sinus. So as you can see here, this is the lateral wall of the cavernous sinus. Okay. So in the lateral wall, can you see some?
Yeah. I'm trying. It's
You can-
not recent.
You can see some nerves along the lateral wall of the cavernous sinus. One is the oculomotor, then you have the trochlear nerve, then we have the ophthalmic nerve. The maxillary nerve was earlier included, but now it is not included. According to the latest edition of Gray's Anatomy, maxillary nerve is never included as a part of the lateral wall. It is present in the floor, but it is covered by the meninges. So you don't include maxillary nerve here. So when you talk about the lateral wall, it is always oculomotor nerve, trochlear nerve, and ophthalmic nerve. Now this relation is very, very important. Now there are two structures which are forming the content, that is what is present inside the cavernous sinus are these two structures. One is the internal carotid artery and the abducens nerve. So these two connections are very, very important. Please remember all these connections because we'll need this when we are talking about the applied anatomy. Okay. So I have, so this is what flow chart. Maybe you can make a flow chart like this. I've taken this from Dr. Yogesh Sandake's book. He has a pretty good, all these flow charts, which are very easy and helps you in quick revision. So I have written everything, the location, the paths, extent, relation, everything I've written here. Now, another thing which we should discuss when we are talking about the cavernous sinus is the communication. How is the cavernous sinus becoming a dangerous sinus? Why is that happening? Now, communications of the cavernous sinus are pretty important. So, if you see here, this is one of the dangerous communication. That is the facial nerve, the communication of the facial nerve to the cavernous sinus. Okay, so facial nerve is communicating to the cavernous sinus with the help of ophthalmic veins. Okay, ophthalmic veins, the superior and inferior ophthalmic veins. So, it will be communicating the facial vein, which is draining on the face, is communicating to the cavernous sinus with the help of ophthalmic veins. That is one very, 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 very important communication. Another one is the facial vein, which is communicating to, so I have another picture here. Yeah. So another is the facial vein, which is communicating to the cavernous sinus with the help of emissary vein. So if you have learned the base of the skull or the interior of the cranial cavity, you might have come across two of these small foramens, which are foramen ovale, spinosum. So you have some emissary veins which are coming out through these foramen. Now, especially the foramen ovale, the male structures, if you remember, the emissary vein. Now, through this emissary vein, the facial vein is connected to the cavernous sinus. So that is another. Now, you know that in the face, there is something called as the dangerous area of the face, which is just present below the nose. So that area, if any pimple is infected, you have some kind of infection below, the infection can spread straight to the cavernous sinus. Now, that is why I told the communication of the facial nerve to the cavernous sinus is the most important among all the communication that we are going to discuss. Because, see, cavernous sinus has a lot of communication. It has communication from the orbit, it has communication from the meninges, from the brain. So, it has too many communication. But among all of them, the communication from the face is very, very important and it has a lot of clinical applications. Okay. So that is all about communication, and I think this is a pretty good diagram where you can see how. And see, one thing you have to remember: if the right cavernous sinus is affected, then the left will be also affected. These are paired sinuses. So why? Because they have two intercavernous sinuses. So both the sinuses will be connected with the help of anterior and posterior intercavernous sinus. So this is very, very important. So it is not like one, if the right is affected, the left will be spared. No, both of them will be affected equally. Now, please note here, you can see the central vein of retina, which is also draining into, it is one of the tributary of the cavernous sinus. We need that when we are talking about the applied anatomy. So that is one thing that you have to remember. Now, the applied anatomy, what you have to see is the cavernous sinus thrombosis. When there is a thrombosis of the cavernous sinus, then you will have a lot of manifestations. Okay, there are a lot of clinical manifestation that happens. One, okay, let me tell you. One is painful ophthalmoplegia. Why does ophthalmoplegia happen? Ophthalmoplegia happens because you know that there is oculomotor nerve involved. So the eye movements are going to be restricted. Okay, so then you have chemosis. Chemosis is because the orbital veins are affected. So you will have chemosis. Then there is something called as pulsating that is pulsating exophthalmos. Exophthalmos is the protrusion of the eyeball beyond the orbit. Now, why do pulsation of that is pulsating of the exophthalmos happen? It is because you know that the cavernous sinus, the content inside is the internal carotid artery, and the cavernous sinus is actually a vein. So when these two things, then there is a communication between the internal carotid artery and the cavernous sinus. Then with each pulsation, what will happen with each pulsation which is passing through the internal carotid artery, the eyeball will start pulsating. Okay, so that is one of the important things that you should remember about the cavernous sinus. So eyeball ophthalmoplegia, then there is ptosis, and then there is chemosis, and there is pulsating exophthalmos. So these are there are too many applied aspects. Now this is one of the important thing that you should. These are some of the important aspects that you should remember about cavernous sinus. So scalp and cavernous sinus are two questions that I frequently encountered when I was searching through the papers, when going through the papers. So these two are very, very important. Now, the parotid gland. This is one another frequently asked question, the parotid gland. So you should be knowing the location, the relations, the contents, blood supply, nerve supply, and applied anatomy. So you know that all this location, relation, everything you know. Now what we'll be focusing will be the structures inside the parotid gland and also the nerve supply, the nerve, how it is coming out, the facial nerve, which is very, very, very important now. So we'll be talking about those two structures, those two things prominently here. Now, you know that the parotid gland is actually located below the external aqueous meatus. It has a superior border, it has an anterior border, it has a posterior border. This is the apex, and here we have the base of the gland. So these are the different external features of the gland. Now, the surface is, when we talk about the surface, this surface is called as the superficial surface. Okay. And then we have an anteromedial surface and a posteromedial surface. Okay. So these are the three surfaces of the gland. Now, if you look at the anterior border, this is the anterior border. It has a posterior border. And now when we look at the anterior border, you can see the branches of the facial nerve coming out through the anterior border. Okay. We'll see that later. Now, another important structure that is coming out through the anterior border is the parotid duct. This is very, very, very important, the parotid duct, and where it opens. So it is opening into the vestibule of the mouth. Okay. So that is the parotid duct. Now that is one important structure. We always keep it for spotters as well as even for the BDS examination. This is a commonly asked question, the parotid duct, where it opens. So you need to identify. Now, this parotid duct also acts as the landmark to identify the two branches of the facial nerve. So you know that there are 5 branches of the facial nerve like this. So there is temporal branch, then there is zygomatic branch. You have temporal, there is zygomatic, then buccal branch, there is a marginal mandibular, and there is cervical branch. Now, the buccal branch can be divided into two. One is the upper buccal, another one is the lower buccal. So the upper buccal and lower buccal are position relative to the parotid gland. The one that you find above the parotid gland is the upper buccal, and the one that you find below is the lower buccal. Okay. Now, one more point I need to add about is the capsule of the parotid gland. So if you see here, this is the capsule. Now, you know that there are two kinds of capsule. One is the true capsule, another one is the false capsule. Now, when you talk about the true capsule, it is actually the condensation of the stroma, and the false capsule is actually derived from the investing layer of the deep cervical fascia. Now, this actually splits. So, it is coming from the neck and it actually splits into two. There is a superficial lamina, and here we have a deep lamina. Now, the superficial lamina is actually, it has one applied anatomical importance. That is why I'm stressing on this. So, the superficial lamina, it is actually becoming continuous with the epimysium of the masseter muscle. Okay, so it is becoming continuous with the epimysium of the masseteric muscle. And that is why, so this becomes unyielding. That is the term that you should, yeah, it is written here. It is thick, strong, and unyielding. So when there is a parotid swelling, the pain will be, we'll have experience severe pain because the fascia is unyielding. Okay, so that is one of the importance of the false capsule. I mean, false capsule, the superficial lamina. Please remember this point. This is very, very important. Okay. So the facial nerve is another topic that is I'm not discussing it right now. Now we'll move on to the next topic, which is tongue. Now this question has also been asked too many times, so that is why I'm tongue. Now you should know the features of the tongue. This is relatively easy when compared to the other topics we have discussed now. So you know that the tongue, you should know the features of the tongue, the papillae of the tongue, the muscles of the tongue, the nerve supply, lymphatics, and applied anatomy.
Dr.
Now,
Nikita, can you go to full screen?
okay, ma'am. Ma'am, when I go to full screen, the problem is the cursor is not appearing. It's okay, it's fine. Okay, so the features, when you talk about the features, the main feature is, as you can see here, we have the tongue can be divided into, there is an anterior 2/3, there is a posterior 1/3, and a posterior most part. My cursor is not appearing when I'm doing this, ma'am. So that is why I don't know, my cursor isn't. Okay, so okay, no problem. So what we're going to do, okay, so the tongue is divided into, there is an anterior 2/3, there is posterior 1/3, and there is a posterior most part. Okay, so these are the different parts of the tongue. Now, so features, when we talk about the features, it is mostly papillae. Okay, so when you talk about the papillae of the tongue, there are four papillae for the tongue. There is a filiform papillae, then there is and can I just use the cursor for a bit? Is that okay?
You can.
Yeah, thank you, ma'am. Oh my God. I don't know, ma'am, something happened. My PPT.
What's happening? Open your presentation, yeah.
Ma'am, it closed. I don't know how.
Yeah, it's okay.
Okay. Ma'am, can you see this?
Yes, we can. You can continue.
Okay. So here we have now if I talk about the tongue, so you can see there are different papillae for the tongue. So you might be knowing the different papillae. There is fungiform papillae, there is filiform papillae, and then we have the foliate papillae and the circumvallate papillae. So these are the different papillae of the tongue. Now, which one is so most of them have taste buds except the filiform papillae. The foliate papillae is one that you will see mostly in animals and also in children. Okay. Now, the circumvallate papillae is very important because we will talk about the circumvallate papillae now. Now, the muscles. Next, we are going to talk about the muscles. Now, tongue has both extrinsic and intrinsic muscle. Okay. So, tongue is having both extrinsic and intrinsic muscle. The intrinsic muscle include the superior longitudinal, inferior longitudinal, there is vertical muscle. Now, intrinsic muscle is just to change the shape of the tongue, but extrinsic muscle is what is more important. Now, all those muscles which are surnamed as glosses are forming the extrinsic muscle. So, as you can see here, there is xyloglossus, there is palatoglossus, there is hyoglossus, and there is genioglossus. Now, one thing applied anatomy about the genioglossus is that this muscle helps in protrusion of the tongue. So this muscle is very important. It helps in protrusion of the tongue. So when this muscle is paralyzed, there is a chance for tongue falling back and then closing our laryngeal opening. So that is very important. The genioglossus is also called as the safety muscle of the tongue. Okay. Now, we'll talk about the nerve supply of the tongue. That is very, very, very important. Now, all the muscles of the tongue are supplied by all the motor supply is by the hypoglossal nerve, whether it be intrinsic muscle, extrinsic muscle. So you can write it down somewhere. All the muscles except palatoglossus will be supplied by the hypoglossal nerve. So hypoglossal, as you know, is a purely motor nerve, and all the muscles of the tongue except palatoglossus will be supplied by the hypoglossal nerve. Okay, so what is supplying the palatoglossus? That is from the pharyngeal arches. Okay, cranial root of accessory via vagus. So rest everything will be supplied by the hypoglossal nerve. Now, sensory supply. This is very, very, very commonly asked question. The sensory supply of the tongue. Now, when you talk about the sensory supply of the tongue is one organ which, apart from having the general sensation, that is the cold, the touch, temperature, and pain, this one has another extra sensation, which is the taste sensation. Okay. So taste sensation. Now so when we talk about the sensory supply of the tongue, you should classify it into general sensation and special sensation. Okay. Now the anterior two-third of the tongue is the general sensation is by the lingual branch of the mandibular nerve. Okay, mandibular nerve in the posterior division, there is a lingual branch, and this is coming from the lingual branch of the mandibular nerve. Special sensation is by the coda tympani branch of facial. Special sensation is by coda tympani branch of facial nerve. You know that the facial nerve gives off a branch which is called as coda tympani, and it joins the lingual nerve on its way to the tongue. So that is coda tympani. Now, As you can know, so when the tongue is divided into anterior two-third and posterior one-third with the help of this V-shaped sulcus, which is called as the sulcus terminalis. Now, in front of the sulcus terminalis, you will see this kind of a valid papillae, which is called as the circumvallate papillae. Now, you might be thinking that the circumvallate papillae, since it comes in the anterior two-third, is also supplied by the lingual branch of the mandibular nerve. No, or the chorda tympani branch of the facial nerve. No. It and the posterior one-third of the trunk, along with the circumvallate papillae, both the general and sensory supply is by the glossopharyngeal nerve. So it has something to do with the embryology because of the difference in the development of the arch. Okay, so both of them will be supplied by the glossopharyngeal nerve, both sensory and the general part. Now, the posterior most part of the tongue, which is the laryngeal part of the tongue, it is supplied by both general and sensory, will be done by the superior laryngeal branch of vagus nerve, that is internal laryngeal nerve. Okay, so it will be supplied by internal laryngeal nerve. Okay, so this is one thing. Please remember the motor supply, the hypoglossal nerve that supplies all the motor muscles of the tongue, except the palatoglossal, and the sensory supply. Please remember the circumvallate papillae is supplied by glossopharyngeal nerve. Okay, next, another important question that is commonly asked is the facial nerve, which is very, very important. This question has been asked too many times, the facial nerve. So, when you're talking about the facial nerve, you need to know the origin. You have to talk a little about the course, especially the course in the facial canal. So, you know that when you're studying the middle ear, you might have seen the facial canal, which is present in the roof as well as in the posterior wall. So, that is important. Please mention facial canal when you are talking about the course of the nerve. Then its course inside the parotid gland and also the branches and applied anatomy. Okay. Now, what I can tell you about the origin. So this is one area where students get confused about the origin. So when you're talking about the origin, please mention about, so you know that it is taking origin from the pons, everything agreed, but it would be great if you can mention the nucleus, okay? Because this nucleus plays an important part. Now, you know that there is a motor nucleus of the facial nerve because facial nerve is motor to all the muscles, which are all the muscles of facial expression. So it is quite important, the motor nucleus of facial nerve. Then you know that it is also secretomotor. Okay, so it is secretomotor to the sublingual and the submandibular salivary gland. So it needs to have a parasympathetic nucleus, and that nucleus is the superior salivatory nucleus. So please mention the superior salivatory nucleus. Okay, so now we have discussed the motor part. Then we have discussed the glandular part, which is the superior salivatory nucleus. And so remember we mentioned about the chorda tympani nerve that was carrying the taste sensation. So we need to have a taste nucleus, right? And that is the nucleus of Tractus solitarius. So this is the other nucleus. Okay. Then, so these are the three important nucleus that you should remember. Now, why I have had its spinal nucleus of trigeminal nerve is because the facial nerve also carries sensation from the external ear. So it is a bit important why it carries sensation from the external ear. Now, finally, this has to reach. So you can see it is carrying through the external ear, from the external ear, and just going to the spinal nucleus of trigeminal nerve. So finally, it has to relay in the trigeminal nerve nucleus. So that is why I have included that too here. So remember, if you don't remember this also, it's fine. But please remember to mention all these nucleus that we have discussed right now. Now, when you talk about the course, please mention about its course in the internal ear, how it courses in the internal ear, and it enters the middle ear, and through which canal it exits. So it exits through the stylomastoid foramen. Now, as it exits through the stylomastoid foramen, it supplies all these, gives of these branches, the posterior auricular branch. Then it gives off the posterior branch to the posterior belly of digastric stylohyoid. This is always a common spotter question where these posterior belly of digastric will be pinned and you'll be asked what is the other muscle which is supplied by the same now, because they two come together and they belong to the second arch. Okay. Now, after that, it is going to enter into the parotid gland. Now, in the parotid gland, it is going to divide into, so here I have a picture. So inside the parotid gland, the facial nerve is dividing into two trunk. Okay, so it has a temporofacial trunk and a cervicofacial trunk. Now, the temporofacial trunk is going to divide into a temporal branch and a zygomatic branch. And the cervicofacial will give rise to upper buccal, lower buccal. See, you can see the parotid duct in between. Then the marginal mandibular branch and the cervical branch all are going to supply the muscles of facial expression. So please do mention all these things. Now, see, so this is the course of the nerve inside the parotid gland. So as you can see here, the structures which are inside the parotid gland, you can see the facial nerve. first. So we're going from above downwards, that is superficial to deep. You'll see the facial nerve. Then we have the retromandibular vein and the deeper structure, which is the external carotid artery. So facial nerve is the superficial most structure that you're going to see, and you need to know about each of these branches. Okay, so through it is coming all coming through the anterior border. You need to know that, and then it supplies the muscles of facial expression. Okay, so I think nucleus is one place where students get confused. So you need to know that these are the different nucleus. Now, you know what is the most important applied anatomy of the facial nerve? It is nothing but the Bell's palsy. Okay, so there will be difficulty in closing eyes, drooping of the mouth corner, the facial expressions will be affected. So Bell's palsy is one thing that you have to remember. Okay, then next is temporomandibular joint. Now, you know that this is a very, 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 very important question and a commonly asked question. Why? Because this is the only movable joint in the skull region. In the head. So this is a very, very important joint. Now, when you're talking any joint, for that matter of fact, when you talk about any joint, you have to follow these rules. The first thing that you have to write is articular surfaces. Which are the articular surfaces of the gland? Okay, of the joint. Next is the capsule. What are the structures which are capsule and ligaments? The things that are going to strengthen the surface, strengthen the joint. And next will be movements and the muscle causing movement and applied anatomy, if there is any. So that is the most important. That is how you follow. This is the basic guideline for writing any answer which is related to a joint. Okay, so you need to know the articular surface, which is the superior articular, which is the inferior articular surface, the capsule, anytime it will be fibrous capsule, and then the ligaments which are strengthening the joint, the movements with the muscles and applied anatomy. Okay, so this is one thing that you have to follow invariably when you're writing about any joint. Okay. So here I have just skipped an articular surfaces. So here you can see this is the formed by the squamous part of the temporal bone. So you know all that things here, the articular eminence, articular fossa. And then you have the inferior articular process, which is mostly formed by, it is not mostly, it is formed by the head or the condyle of the mandible. Okay. Then this is one important thing. Now, when you're talking about the joint, so you can tell that a temporomandibular joint is a complex kind of synovial joint. Now, why did I call it a complex joint or a compound joint? Why? Because it has an intra-articular disc. So can you see the intra-articular disc here? It is dividing the joint cavity into a superior meniscotemporal compartment and an inferior meniscomandibular compartment. Okay. So that is the importance of the intro. So that is why you call this as a compound joint or a complex joint. There is an upper compartment and a lower compartment. Please do not forget to mention this. Another thing that I would want to tell you is the ligaments. Okay. So you know that there is a joint capsule. Yes. So there is joint capsule. Now, one thing that you have to remember about the joint capsule is that the lateral pterygoid muscle, the upper head, is actually going to extend into the joint capsule. Please remember that point. That is important. And the second one is lateral ligament. So it is going to prevent the sideways displacement of the mandible. Then, you know what is the sphenomandibular and the spinomandibular ligament is. From the name itself, you can understand what is a sphenomandibular ligament, which is starting from the spine of the sphenoid and is going to the lingula of the mandible. Lingula is that structure which is present near the mandibular foramen. Then we have a stylomandibular ligament, which is extending from the styloid process to the angle of mandible. Okay. So these are the important ligaments. I just finished it in 1 minute. This is all what you need to know about the ligaments. Okay. Mention the joint capsule and the other ligaments. When you're mentioning about the intra-articular disc, please mention the extension of the joint capsule. You have to mention the extension of the lateral pterygoid. Okay. So I have, made it a tabular column. It is taken from Dr. Yogesh Sendeke's textbook. So this is how you can, it is easy for correction as well. And you can revise it very fast when it is written in this way, because these are the important points that that is required. You can just expand it a little bit, like you can add a few points about the capsule, but this is what is expected from you. So it helps in quick revision too. Now, the muscles. There is temporalis, then there are pterygoid muscle, then there is masseter, and there are other accessory muscles too. So this together, you call this as muscles of mastication, you know that. So what you should remember here is the only muscle among the muscle of mastication, the only muscle that helps in opening the jaw, that is lateral pterygoid. Okay, rest every muscle is helping in closing of the jaw. Please remember that point. The lateral pterygoid muscle, it is the muscle that helps in depression of the jaw, that is opening up of the mouth. And there are other muscles too, like gravity, there is digastric, genohyoid, mylohyoid. You know that all these are suprahyoid muscles and they'll be attached to the mandibles. Obviously, they're going to pull it down. Okay. Then elevation, all other muscles which will help in elevation. See, masseter, medial pterygoid, temporalis, as I mentioned, all the muscles of mastication except lateral pterygoid is helping in closing of mouth. Now, protrusion, there is medial and lateral pterygoid. Retraction, so when medial and lateral pterygoid, they act together, you'll have protrusion of the mandible. Retraction is the fibers of temporalis, and the side-by-side movement is the alternate contraction of the medial and lateral pterygoid. Okay, so from this, please remember about the lateral pterygoid, how it is the only muscle that helps in opening of the jaw. Now, all these muscles are supplied by the branches of the mandibular nerve. Okay, anterior division of the mandibular nerve is going to supply all these muscles of mastication. Okay, so I just added another, I saw this question as one, so that is why I told muscles of mastication. So all you have to know is just have a brief idea about the origin and insertion. Not the extensive origin like the anterior 2/3 and 1, not like that, just from where it is taking origin, which bone it is taking origin, at least that is important like this. For example, masseter, zygomatic arch, that is more than enough, the zygomatic arch and where it is inserted. And then you have to know about the nerve supply. Okay, so when a muscle is asked, it is not about the anterior 1/3 and the 3/4. No, it is just the bone that is more and more important. Okay, so that is muscles of mastication. We have already discussed it while discussing temporomandibular joint. Next, I saw this question being asked so many times. So maxillary artery is very, very, very important. Okay, so you know that maxillary artery is actually one of the terminal branches of the external carotid artery. Okay. Now, the other terminal branch is the superficial temporal. So, regarding the maxillary artery, you should be knowing the origin, okay, the paths and relation, the branches, distribution, and applied anatomy. Okay. Now, origin, you know that it is taking origin from the external carotid artery. Okay. Now, when we are talking about the artery, now, whenever you talk about an artery, when you talk about the origin, its termination, you should always mention a bony point. Okay, so here origin is from behind the neck of the mandible within the parotid gland. You have to mention the bony point. That is one point that students miss when they write the exam. And so when origin is asked, you should write about the parent vessel and its level of origin. That is from, you should mention, you know that arteries are always palpated against bones. So you need to mention the bony point. Now, parts and relations. So when you are talking about the artery, the maxillary artery, it is divided, or it has three parts. You know that there is a first part, there is a second part, and there is a third part. Now, all these parts are described in relation or relative to the lateral pterygoid. So, lateral pterygoid, you know, is the key muscle of the infratemporal region. So, in the infratemporal fossa, you will find the maxillary artery. Yes. So, in the lateral pterygoid, why is the lateral pterygoid called as the key muscle of the infratemporal region? Because the maxillary artery and so many nerves and muscles of this region are coming in relation to the lateral pterygoid. Okay. So based on its relation of the maxillary artery to the lateral pterygoid, you can divide it into a first part, which is present below, a second part, which is present either superficial or deep, and there is a third part that ends into or enters into the pterygopalatine fossa. So these are the three parts of the maxillary artery. Now, each of these branch parts have so many branches. Okay. Now, I have actually summarized the region of supply of this, which is very, very, very important. In the first part, and I've even added some mnemonics too. Now, the first part, as you know, there are too many branches. There is deep auricular, anterior tympanic, but one branch that you should not miss while mentioning the artery from the anterior part or the first part is the middle meningeal arteries. You know how middle meningeal artery is very, very important. It supplies the dura mater. It enters the cranial fossa through the foramen spinosum and it is supplied in the cranial dura mater. You can almost see the impression of the middle meningeal artery when you take the cranial vault. You might have noticed the impression of the middle meningeal artery over there. And then from the second part, it is all the muscular branches. Okay. So second part, you will have muscular branches, which are going to supply the muscles of mastication because this artery is present in the infratemporal fossa. Now, third part you will have, so remember it as spic pars, okay? So out of the spic pars, the one artery that is important is the sphenopalatine. You know how the sphenopalatine artery is entering into the nose, the lateral wall of the nose, and it forms anastomosis. So it is a very big, it's a very important artery, and that artery is thought to be the continuation of the maxillary artery. So if in any MCQ question it is asked, what does the maxillary artery continues as? Continues as the sphenopalatine artery. Another artery of importance to you is the inferior alveolar artery. So you know that it is entering into the mandibular canal, and inferior alveolar artery will be supplying the teeth of the lower jaw. So it is also quite important. Okay. Now these are the important key points that you should remember while you are revising the maxillary artery. And the distribution, if you see the mandibular part, it is mostly the branches are from ear, tympanic cavity, the dura mater, mandibular teeth. Pterygoid part is mainly for the muscles, and pterygopalatine part is the one that supplies the teeth, the sinus, nasal cavity, hard palate, soft palate, pharynx. So everything is supplied by the maxillary artery.
Doctor,
Then, yes.
the slides are not visible is what the students are saying. Can you project it? Can you make it?
Yeah.
full?
Okay. Yeah. Okay, ma'am. Now is it okay, ma'am?
Yeah, it is.
Okay. So thyroid gland. Now this is very, 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 very important. Okay, thyroid gland. And this gland is pretty important. And this question has been asked too many times. So what you should remember is the situation. You know, it is present in front of the neck and its relation. Okay, so each each surface of the thyroid gland and its relation. Now we're running out of time, so I'll just discuss the applied anatomy. Now, what you should remember regarding the applied anatomy is the apex and the base of the triangle. So, all this extent I have given here. Now, blood supply is one thing which is very important as far as I'm concerned. The blood supply is the most important part of the thyroid gland because thyroidectomy is a very common procedure. So, you need to know about the blood supply of the thyroid gland. So, when you see the apex of the thyroid gland, it is mainly supplied by the superior thyroid artery. Okay. And when you see the base, it is supplied by inferior thyroid artery. Now, the superior thyroid artery, and what is it? The next question will be, what is it a branch of? Superior thyroid, as you can see, is a branch of external carotid, and inferior thyroid is actually a branch of the subclavian artery. Okay, these 2 points, please remember, it is very, very important. Now, the nerve supply. Okay, this is where the applied aspect comes into play. Now, if you see the superior thyroid artery here, it is accompanied by a nerve, which is called as external laryngeal nerve. As you can see in the picture, it is supplied by external laryngeal nerve. Now, external laryngeal nerve is a nerve that supplies the cricothyroid muscle. Okay, it is one of the muscles, extrinsic muscle. There are too many muscles in the larynx, and this is one muscle which is placed externally. Now, this is one muscle that has the function which helps in increasing the length of the vocal cord. So, it is a pretty important muscle, the cricothyroid. And this muscle is supplied by external laryngeal nerve. So, when you are, when we are ligating the artery, so when we are doing a thyroidectomy, we need to ligate the artery, right? So, when we are ligating the superior thyroid artery, it is ligated close to the apex because when you see, if you see near the apex, the thyroid artery and the external laryngeal nerve, they have been traveling together. From its origin, the nerve has been traveling together, but as soon as it reaches the apex of the thyroid gland, it diverges. So the best way to ligate the artery is close to the apex. That is, superior thyroid artery is ligated close to the apex to avoid any kind of injury to the external laryngeal nerve. Okay? Then, if you look at the base, you have the inferior thyroid artery and the recurrent laryngeal nerve. They have been traveling together. They have been, so the superior thyroid artery is ligated close to the apex. The inferior thyroid artery is ligated away from the base because, as you can see, they have been traveling at a distance till the time it reaches the base. Okay, so so it is always better to ligate the inferior thyroid artery away from the base because these two structures, that is the recurrent laryngeal nerve and the inferior thyroid artery, they come together near the base. So it is close to the apex, away from the base. Please remember that. Now, what happens if this recurrent laryngeal nerve is affected? We're discussing about this in the larynx because recurrent laryngeal nerve supplies all the muscles of the larynx except cricothyroid. So it is that important. It can lead to vocal cord palsy. Okay, so that is why this is very, very important. Close to the apex, away from the base. Okay, fine. Now, the next question commonly asked is larynx. You should know about the cartilages, which are the paired and unpaired cartilages of the larynx. You should know about the joints and ligaments, which are the different joints and the movements, the muscles, the interior blood supply, nerve supply, and the applied anatomy. So I'll be discussing mostly about the applied anatomy. So to discuss that, I need two things here. One is to show you the interior of the larynx. So about the vocal cord, the area below this is area is called as the you can see it is marked as vocal fold. Now above this area, every sensory supply is by all the sensation is carried or supplied by the internal laryngeal nerve, and below it is by recurrent laryngeal nerve. The internal laryngeal nerve is the purely sensory nerve. Now if this nerve is affected, what happens? You lose the sensation, which all these cuff reflex. So imagine a foreign body entering into your larynx, you immediately cough it out, and that is because of the sensation of this carried by the internal laryngeal nerve. Below it is by the recurrent laryngeal nerve. So these two nerves, when it is affected, it is very, very, very important. Okay, so internal laryngeal nerve, purely sensory nerve, it supplies above the vocal fold. Affected, if it is affected, the cuff reflex will be lost, and below the vocal fold, it is supplied by recurrent laryngeal nerve. It is a mixed nerve, so it gives sensation below the vocal fold. Now, another thing that you should remember is one more applied anatomy from this region is the muscle. Okay, so there are too many muscles in the larynx. Now, one muscle you should remember is one, as you can see, the third picture here, the green muscle, that is the cricothyroid muscle. As I mentioned, it helps in lengthening of the vocal cord. And the next muscle that you should remember is posterior cricoarytenoid. It is called as the safety muscle of the larynx. Okay, why? Because it is the only muscle that helps in abduction of the vocal cord. Although there are other three muscles which help in adduction, posterior cricoarytenoid is the muscle of abduction of the vocal cord. So if this is paralyzed, it would be very difficult because you are almost closing the air entry, right? So posterior cricoarytenoid, please mention posterior cricoarytenoid and cricoarytenoid. Okay, cricothyroid and posterior cricoarytenoid. Very, very important. Posterior cricoarytenoid, safety muscle, helps in abduction of the vocal cord. Cricothyroid helps in lengthening of the vocal cord. And all the muscles of the larynx except cricothyroid will be supplied by which nerve? The recurrent laryngeal nerve, and cricothyroid will be supplied by external laryngeal. Now, when you talk about the next is pharynx, very important. You need to know the parts of the larynx, the muscles, blood supply, nerve supply, and the applied anatomy. Okay, so the muscles. When you talk about the muscles, there are different. There are two sets of muscle. One is the circular muscle, another one is the longitudinal muscle. So you should know there are different muscles. Okay. Now the circular muscles are called as the constrictor. Okay, so these are superior constrictor, middle constrictor, inferior constrictor. You should know about all these muscles. Its origin and insertion. Its origin and insertion is important. Then you have the other muscle, which is the longitudinal muscle, three pharynges, stylopharynges, palatopharynges, and salpingopharynges. Now, when you talk about the pharynx, everything is actually applied anatomy. All the levels of the pharynx. If you take nasopharynx, it has so many applied aspects. For example, the adenoids. What are adenoids? So those are enlargement of the nasopharyngeal tonsil. Okay, and they block the opening of the eustachian tube. So the child will have it will have mouth breathing, clustering of teeth. Okay, so that is adenoid. So each of these has applied aspect. I think it is we are running out of time, so I'll just please know. You need to know the parts, the muscle, blood supply, nerve supply. Now, one thing I can remember is all the muscles of the pharynx are supplied by pharyngeal plexus. Okay, so almost all the muscles of the pharynx are supplied by pharyngeal plexus, except stylopharynges, which is supplied by glossopharyngeal. Now, this except is very, very important. All the muscles of the pharynx, whether it be the longitudinal muscles or circular muscles, all of them will be supplied by pharyngeal plexus, except stylopharynges, which will be supplied by glossopharyngeal nerve. So please, that is very, very important. Okay. The next one is the circle of Willis. Okay. So next we have the circle of Willis. So there are two questions that has been frequently asked from neuroanatomy. One was circle of Willis, another one was internal capsule. Now, when we talk about the circle of Willis, the questions asked was formation, the components, functions, and applied anatomy. So circular villus, first you need to know the location where it is placed. It is placed in the interpedunclar fossa at the base of the brain, and how it is, what is the functional significance? Now that is important. You know that the circular villus is actually a communication between the vertebrobasilar system and the carotid system. Okay, so it is a communication between vertebrobasilar and the carotid system. So these two systems are communicating with each other to ensure that if there is a blocking in the pathway, one of them will take control. I mean, there will be collateral circulation. So to ensure continuous flow of blood in the brain, you have the circular villus. And next is it maintains adequate cerebral perfusion pressure, protects against infarction and ischemia. So that is the functional significance. Now, components, there are different components. Okay, so formation of the circular villus is this. You can see there is a vertebral artery. It becomes the basilar artery. Okay, and then it divides into posterior cerebral artery. Then you have an internal carotid artery. And these systems are, linked together with the help of two communicating branches. Okay, so the branch which communicates, so connects the internal carotid to the basilar artery, or the posterior cerebral artery, is the posterior communicating branch, and the one that connects the two anterior cerebral is the anterior communicating artery. So this is called as circular villus. Now, when you talk about the branches, please write there are cortical branches, there are central branches, there are choroidal branches. Now, cortical branches means they will be supplying the surface, the cortex, as well as the white matter. Okay. Now, central branches, they're also called as lenticulostriate branches. Those are the ones, the ones that you see in the center, those are the lenticulostriate branches. So they basically supply the corpus striatum. Okay, the internal capsule. There are other areas where it supplies. So central branches is mainly for supply of internal capsule. Please remember that point. There are anteromedial, anterolateral, posteromedial, and posterolateral. Okay. Now, the next set is choroidal. There is anterior and choroidal, posterior choroidal artery. Now, why do you have choroidal branches? To produce CSF. So they will be present in the ventricles. Now, that is how you summarize about each of the branches. Cortical branches supplying the white matter as well as the cerebral cortex. The central branches, lenticulostriate branches, that basically supply the corpus striatum, and then you have the choroidal branches that is forming CSF, so will be present in the ventricles. Okay, so that is about the circular villus chest. Now, there are too many applied anatomy. Now, something related to this artery is one thing that you should remember is something called as berry aneurysm. Okay, so berry aneurysm is actually a defect in the tunica media of the vessel. Now, you'll find berry aneurysm at the region of this where these arteries are communicating. That is the most common region. So, where berry aneurysm happens. So, when it is ruptured, it can lead to damage of the brain. So, depending upon the area of damage, you'll have similar clinical manifestations. So, that is berry aneurysm. Now, another thing we'll talk about that in internal capsule. Okay, so I've we'll talk about the other important central branches in the internal capsule. This is the last most important topic that you should remember. You should know what is an internal capsule. So you might be knowing it is a white matter bundle. Okay, and it is present between the thalamus and the lenticulate nucleus. You should know the relation, the fibers, blood supply, and applied anatomy. Okay, see, you can see it is present between the lentiform nucleus and the thalamus. Okay. Now, one thing, so when we are taking a section, okay, so when we are taking a section, what we are seeing here is the parts of the internal capsule. Okay, as you can see, it has an anterior limb, it has a curved genu, it has a posterior limb, and two parts. One part which is present below the lentiform nucleus, which is called as sublentiform, and one which is present behind, which is called as retrolentiform part. Okay, so you need to remember these two parts. Now, when we are talking, I'll just talk about only the important fibers which are passing through the internal capsule. The internal capsule is one region where most of the ascending and descending fibers are passing, whether it be fibers from cerebral cortex to spinal cord, or whether it be fibers going through the thalamus, everything is passing through the internal capsule. Now, one thing you should remember is the posterior limb. Okay, that is where you will find the corticospinal tract, the cortico-rubral tract. All those things are passing through the posterior limb. So it is very, very, very important. Please remember, through the posterior limb, you will find the corticospinal tract passing. So if corticospinal tract is low, then you'll have contralateral hemiplegia. So you need to know what is supplying the posterior limb. That is very, very, very important. Okay. So posterior limb is mainly supplied by an artery which is called as Charcot artery. Okay. Charcot artery is one of the striate branches. Remember, I told you about the central branches. So this is one central branch which is arising from the middle cerebral artery, and that is supplying the posterior limb. It is very important. Please remember that. And it is also, so it is called as the Charcot artery of cerebral hemorrhage. Okay, so that is called as Charcot artery of cerebral hemorrhage. So when that is affected, the person will have contralateral hemiplegia. Now, one more thing, please remember, anterior choroidal artery. Okay, so it is a branch from the internal carotid artery that supplies posterior limb, the retrolentiform part. Now, retrolentiform part, if you see, it is related to the lateral geniculate body. What is lateral geniculate body related to? Optic radiations. Okay, so when the Charcot artery is affected, the person will have contralateral hemiplegia, and also vision will be affected because the optic fibers are passing through this retrolentiform part. Okay, so Charcot artery is called as the artery of cerebral thrombosis. Why? Because the artery is very long and it has a narrow lumen. So this artery is also very, very important. So if you don't remember anything, at least remember the fibers which are passing through the posterior limb is corticospinal, corticorubral, and then you have to remember the artery which is supplying the posterior limb, the Charcot artery, branches the middle cerebral artery. When there is hemorrhage of that artery, then you will experience contralateral hemiplegia. Please remember this. Okay. So the references that I made was BDC, then Snell's Anatomy, Gray's Anatomy for students, and I have even referred Yogesh Sandake for the pictures. I have a suggestion. When you are studying neuroanatomy, I think the Manipal Manual of Clinical Anatomy is pretty good. It's easier when compared to the other textbooks. So you can refer the Manipal Manual of Clinical Anatomy for just neuroanatomy. It is really easy, especially the cerebellum part and all. It's very easy. Among all the books of neuroanatomy, I found that a bit, easier. Thank you.
It was a very good session. Do we
Thank
have
you, ma'am.
any questions?
Ma'am, I think I can share this slide to the students because I have summarized everything. So if they want a quick revision, they can go through that.
That will be very helpful.
Yeah, you can share the slide. I'll send this modified slide, ma'am, just adding a few more points. So it'll be very useful for quick revision because I've summarized everything.
Okay, fine. Thanks
Yeah.
a lot. If there are any questions?
No, ma'am. No, ma'am.
No. Thank you. Thank you, Dr.
Thank you,
Nandita,
ma'am.
for the
Thank you, ma'am.
informative session. You had
Hello,
summarized
ma'am.
everything very well.
Hello.
Yes.
Hello.
Yes.
Hello.
Is there a question?
Can we get notes of these lectures, ma'am?
Yeah, sure. I can share you this PPT. So in case, that is what I told. I've summarized everything, so you can go through it. Okay, for a quick revision,
Okay,
I
ma'am.
have included all the important points. You can just
Okay.
revise it
Thank
in
you, ma'am.
5 minutes. Yeah.
Thank you.
Thank you, ma'am. Thank you for that insightful session.
Thank you. Thank you for inviting me, ma'am.
Welcome. You're welcome.
Okay, now moving on to our next speaker. It's my pleasure to introduce Dr. Priya S.A., Associate Professor in Physiology at JSS Medical College, Mysore. She completed her MBBS and MD in Physiology from Mysore Medical College, and she has vast experience in medical education and research. She has presented scientific papers at various national and international conferences, and she has several research publications to her credits. We warmly welcome you, ma'am. Over to you, ma'am.
Dr. Priya, you can start your screen share.
Yeah, am I audible?
Yes, you are, ma'am.
Yeah. Good morning, everyone. Good morning, students. Good morning, organizers. So I'll be sharing my screen now. Is the PowerPoint visible?
Yes.
Yeah. Okay. So a warm Good morning to everyone. So I'm Dr. Priya. So I'm the Associate Professor of Physiology. So physiology, as you all know, it's the bodily function. How does our body function? So far, you have learned about the anatomic part, the structure, how the structure is made up of. So you'll be learning now how our body functions related to these structures. So our basic pillar of physiology is homeostasis. Homeostasis is any disturbance in our body. It corrects, our body knows how to correct it. So the mechanism involved in correction of these bodily processes and being making our body stable or maintaining the internal environment stable is known as homeostasis, and that is the motto of physiology. So in physiology part, basically you'll be asked to describe the procedure, the mechanisms involved in various things which are involved, basically involved in your field like pediatric dentistry. So when I went through many questions, okay, so some of the questions related to the blood were anemia, immunity, inflammation and wound healing, because you day in and day out are dealing with many surgeries and tooth extractions and all that. So inflammation and wound healing is the main frequently asked question in over the whatever questions I have collected from various parts of the India. Okay, then blood coagulation they'll be asking in related to blood chapter. In cardiovascular system, it's the emergency. Okay, the anaphylactic shock is most frequently asked question. And when it comes to central nervous system, as you all know, pain is the one what the patient comes to you. Okay, that is the time when they come to you. And also after your procedure is over, they suffer a little bit of pain. So you should be knowing how this physiological process of this pain is going to occur. Okay, so that I'll be dealing. And then when it comes to endocrines, it's the growth hormone and parathormone. As you all know, pediatric age is the age of growth. So growth hormone is frequently asked, and parathormone is dealing with the blood homeostasis of the calcium. Okay, so these two are frequently asked. And when it comes to gastrointestinal tract, saliva is the frequently asked question in the physiology. So I'll be covering in a nutshell all these portions. Okay, but remember, physiology is normal functioning of the body. So any disturbance in this body for brief period of time, our body responds to it to correct it. Okay, so this is all about physiology. The disturbance, if it is not corrected immediately by the body, then the doctors have to intervene. That lands up in pathology. Okay, so coming to the first one, what we are going to deal with is hemostasis. This is different from homeostasis. Homeostasis, just now I told you, it is the maintenance of internal environment, constant. Okay, whereas hemostasis is arrest of bleeding by physiological process. Okay, so day in and day out, you are going to see all these blood stained areas like during surgeries and all that. So you should be knowing how this bleeding occurs physiologically and how it is stopped immediately. That is what the area of hemostasis is concerned. So if they ask you a question about the blood coagulation or hemostasis, you should be knowing what is the normal definition. So it's the spontaneous arrest of bleeding or prevention of bleeding by physiological process. This hemostasis involves interlinked complex processes. Those are vasoconstriction, formation of temporary hemostatic plug, and formation of definitive hemostatic plug. These three are the major steps in arrest of bleeding by physiological process. So what happens whenever there is injury? Okay, so whenever there is injury, immediately the blood vessels surrounding the blood components, it starts to contract. This is known as plasticity. So when they start to contract, or there is vasoconstriction, that will reduce the blood flow and the amount of bleeding, if it is a minor, it is going to stop because of this vasoconstriction. But if the injured site is still bigger, then there comes the temporary hemostatic plug formation. This temporary hemostatic plug formation involves the role of platelets, okay, the formed element of blood. So this platelet, it is going to adhere to the injured site, okay. So when they adhere, it undergoes activation. These platelets contains granules. These granules are going to get released. This is known as activation, platelet adhesion, platelet activation, and then comes platelet aggregation. As you can see in this picture, the platelets go on aggregating on one another. They become sticky and they start adhering to one another. So when they adhere to one another, they block or seal the site of injury. And this is how they control the bleeding. This is known as temporary hemostatic plug. Okay. If the site of injury is very small, then you're going to see this temporary hemostatic plug is enough to control the bleeding. But as you all know, you're going to incise the tissue. Okay, when you incise the tissue, injured site will be a slight bigger. Then comes the picture, formation of definitive hemostatic plug. This is nothing but coagulation. What is coagulation? Coagulation is conversion of liquid blood into a solid jelly-like mass. Okay, so this definitive hemostatic plug is a frequently asked question for almost all the university papers that I've seen. Okay, so this formation of definitive hemostatic plug or coagulation involves two major steps. One is intrinsic coagulation, another one is extrinsic coagulation. Remember, in physiology, you need to write the flow chart because it is a mechanism. So if you write the flow chart, it is easier to write the contents involved in that flow chart. Okay, so this is the intrinsic mechanism. Intrinsic mechanism involves some of the clotting factors. Majority of the clotting factors are, the first starting clotting factor is factor 12. This is called glass factor. Okay, so whenever there is blood trauma, it is not the tissue trauma which is going to activate the intrinsic pathway. It is the blood trauma to the blood vessels itself that exposes the collagen. Okay, so the factor 8 is also called glass factor. So this factor gets activated when the blood is exposed to collagen. Okay, so collagen is nothing but the injured endothelial cells of the blood vessels. Okay, so this factor 12 get activated. Soon after factor 12 get activated, the next factor that this activated factor 12 will activate the next subsequent factor, that is factor 11. Then this activated factor 11 in presence of calcium will activate factor 9. This factor 9, activated factor 9 along with factor 8 and calcium will activated factor 10. Okay, so this activated factor 10 along with thrombin and activated 5 forms the prothrombin activator. So the first step in intrinsic pathway is formation of prothrombin activator. So what does this prothrombin activator contain? This prothrombin activator contains factor 5, activated factor 10A and calcium and platelet phospholipids. Okay, so this first step of prothrombin activator will land up in the next step, that is conversion of prothrombin into thrombin, that is in presence of calcium. This is the second step of intrinsic coagulation. So if you see this coagulation cascade, it is the continuous numbers in the Roman numbers, except the factor 10. Okay, so from 12 it is 11, then comes 9, then comes 8, then comes 10. Okay, so the 10 comes later, which forms the prothrombin activator. Okay, so this is how you should remember the intrinsic pathway. Immediately after 12, you write 11, then jump to 9. Don't write 10. 10 will come when it is going to activate the prothrombin activator. So the first step of coagulation is the prothrombin activator formation. This prothrombin activator formation will then forms the thrombin in presence of calcium. This is the second step. The third step is the fibrin thread formation. Before I go to the third step, because that is the common pathway for both intrinsic and extrinsic, so I'll be moving on to the extrinsic pathway. Extrinsic pathway is usually seen whenever there is bleeding occurring because as a consequence of tissue trauma. Okay, so if there is no collagen, blood vessel disruption, it is the tissue trauma which is causing the collagen disruption. Okay, so whenever there is tissue trauma, the tissue factor, that is the factor 3. Okay, so that is going to activate the clotting factor 7. Okay, this activated clotting factor 7 will in turn forms the activated clotting factor 10. From here onwards, it is same as that of intrinsic factor. When activated factor 10 is formed, that will in turn form prothrombin activator in presence of factor 5 and thrombin, platelet phospholipids and calcium. Okay, so this prothrombin activator which is formed will in turn converts prothrombin into thrombin. From here onwards, that is activated factor 10 onwards, it is the common pathway for both intrinsic and extrinsic. So the difference between intrinsic and extrinsic is you require a lot of clotting factors in intrinsic mechanism, whereas in extrinsic mechanism, only 2 clotting factors are required before the formation of prothrombin activator. Okay, so this is how the thrombin is being formed. The common pathway is after the thrombin is formed, the fibrinogen is converted into the fibrinogen monomers. These in turn forms the fibrin fibers, which forms a cross linkage and traps all the formed elements of blood, that is RBCs, WBCs and platelets, and they form a plug which is going to heal the injured site and prevents the bleeding. This is how the coagulation occurs. So there are 2 pathways. These 2 pathways, the flow charts you should be knowing perfectly. Okay, so remember, intrinsic pathway is initiated whenever there is blood trauma, whereas extrinsic pathway is initiated whenever there is trauma to the blood along with the tissue trauma. Okay, so the factors involved in intrinsic pathway are numerous, whereas it is less in case of extrinsic pathway. So this is about the coagulation and the tests for hemostasis. Integrity of this hemostasis is also been asked few times. So as if you remember your first year of this one BDS, you will be seeing the bleeding time. Okay, so you might have done this experiment. Okay, so bleeding time using the Duke's methods, the normal bleeding time is 2 to 5 minutes. This is the usual test you perform whenever you take for tooth extraction or for any other surgeries, dental surgeries you may come across. Okay, then you'll do the clotting time. The clotting time is by capillary tube method. If the normal duration is 2 to 8 minutes, then you should measure the platelet count. The normal count should be 2 lakh to 4 lakh per cubic mm of blood. Okay, so this is the normal routine blood investigation you do. Apart from this, if there is severe bleeding, then you need to land up in some other tests like prothrombin time, activated partial thromboplastin time, and thrombin time. Okay, so I have written the normal duration of each of these tests what you are going to perform. Prothrombin time is going to check the extrinsic pathway, whereas activated partial thromboplastin time will check the intrinsic pathway, and the common pathway is checked by the thrombin time. So thrombin time is usually done and prothrombin time is usually done because you are going to injure the tissue whenever you do the surgery. Okay, so these are the tests that you're going to perform for coagulation. So in the blood chapter itself, the next part what you're going to see is the inflammation. Okay, so you might have encountered all these type of this when you come to clinical side. Okay, so the inflamed or the swollen area shows redness, pain. The patient suffers from pain. So that is what the picture is depicting here. Inflammation has the redness. If you touch there, there will be heat, there will be swelling and pain, and the person is not going to use that structure because there will be dysfunction because of the pain. Okay, so these are the signs of inflammation that you are going to notice. Why this inflammation occur? This is actually a protective mechanism, okay, for any wound, what you are going to see. Okay, so what is this inflammation? Why does this inflammation occur? So whenever, as soon as there is injury, okay, so the mast cells in the interstitium, it is going to release some of the mediators, chemical mediators like histamine, that is going to permeate the blood vessels to allow the neutrophil to come out. Okay, so vascular permeability is there, and this neutrophil will get attracted towards the injured side, and it's going to phagocytose along with the macrophages. This phagocytosed macrophage and the neutrophil, they'll release some of the chemical mediators like cytokines. These are the ones that is going to heal, okay, and removes the pathogen and also acquired immunity is activated. Okay, so this is what is happening during inflammation. And why there is inflammation? Because of this mast cells which are releasing this histamine. So the chemical mediators of inflammation, frequently asked question, remember this. Okay, please remember this, that the chemical mediators of this inflammation from the intracellular site would be neutrophils, monocytes or macrophages and natural killer cells, whereas from the extracellular sites it could be the C proteins. Okay, C proteins are complement proteins. These are released, and the cytokines which helps in the formation of this inflammation. This inflammation is required in order to protect the ongoing prevent the spread of infection. Okay. Then next thing, what is important in blood chapter is anemia. Okay, so anemia, as usual, it's a common, even in common person can find out what is anemia. Okay, so anemia is less hemoglobin and RBC count. Okay, so why? What are the dental consequences you are going to notice in these kind of anemias? So you're going to see pale gums, because of which the nutrition of these gums are affected. So you might see gingivitis. Then there could be glossitis, and there could be angular stomatitis. So all these are the features what you're going to see in the anemia. So what you should remember in anemia if they ask you the question. So the erythropoiesis, the formation of red blood cells. It's the formation of red blood cells that is hindered in anemia. So you should be knowing the process of erythropoiesis. The formation and maturation of RBCs are known as erythropoiesis. So it involves 7 days. Okay, so the early recognizable series what you are going to see in the erythropoiesis cells are proerythroblast, early normoblast, intermediate normoblast, late normoblast, reticulocytes. These are reticulocytes are immature RBCs. Then comes the mature red blood cells. Okay, so what are the changes you are going to see in these 7 days in the red blood cells in order to form the RBCs? The first thing is the size. You can see here the size was around 25 to 30 micrometers, whereas the matured RBC will be just 7.8 micrometers. Okay, so the size goes on reducing from day 1 to day 7. Then the nucleus at late normoblast, it becomes pycnotic and get extruded. So the reticular size and the mature RBC do not contain nucleus. Okay, then the hemoglobin starts appearing in early normoblast, but the full blown hemoglobin starts appearing from intermediate normoblast. Okay, and you can see the hemoglobin goes on increasing as the mature RBC is being formed. Then comes the cytoplasmic color. So initially it was blue in color, and matured RBC becomes red in color. It's because of hemoglobin. Okay, so the hemoglobin was not present in pro and early normoblast. So hence the cytoplasm is blue in color, whereas in intermediate is neutral. It takes up both blue stain as well as the pink stain, is because the hemoglobin just starts to appear. Okay, so this is intermediate normoblast. These are the points you should be knowing under what heading you are going to describe this erythropoiesis. And the last one heading would be the mitosis. So mitosis is the division of the cells. Okay, so the division of the cells stops at after the late normoblast because the nucleus is extruded out. So the number of reticulocytes, whatever has remained, it is going to produce the RBCs. Okay, so this is what you should remember in anemia if they ask you about the erythropoiesis, how it is been formed. Okay, so the factors, why it leads to anemia if RBCs are not being produced is the thing what you should remember is factors necessary for erythropoiesis. The factors would be general factor, that is hypoxia. Okay, so hypoxia is less oxygen supplied to the tissue level. Okay, so this is the one most stimulus that is going to stimulate erythropoiesis, and this hypoxia is going to stimulate erythropoietin. Okay, so erythropoietin and hypoxia forms the general factor. Then you have got the maturation factor, that is after the nucleus has been extruded, how it is going to mature from reticulocytes to RBCs. The maturation factors are vitamin B12 and folic acids. Okay, the nutritional factors that is going to help in maturation of RBCs. Then comes the factors necessary for hemoglobin synthesis. As we all know, hemoglobin contains an heme part and a globin part. Heme part is nothing but the iron. Okay, the globin part is protein. Okay, so the factors necessary for hemoglobin is the nutrition. Okay, the iron, what you take in the diet, as well as the protein. Okay, it should be first class proteins that is going to synthesize the hemoglobin. So what all you require for RBC production is erythropoietin, the general factor, vitamin B12, folic acid, the growth factors, and the factors necessary for hemoglobin synthesis. Any deficiency in all these can cause anemia. Okay, so this is what you should remember in blood chapter, that is immunity, chemical mediators of inflammation, then coagulation, intrinsic mechanism and extrinsic mechanism. Then in anemia, you should remember the erythropoiesis and the factors affecting erythropoiesis, which may lead to anemia causing various dental consequences. Okay, so then we'll move on to the next cardiovascular system. This is an acute emergency condition. It's a life-threatening allergic reaction. It's called anaphylactic shock. Okay, so this anaphylactic shock is frequently asked in majority of the papers which I have seen. Okay, so this is a type 1 hypersensitivity reaction caused by humoral immunity. Humor means the cells which are present in the blood. Okay, the B lymphocytes initiates this anaphylactic shock. Okay, so in case of dental, when you are going to encounter this anaphylactic shock, even you never imagine this might occur as a consequence of your procedure, whatever you are doing. So it might occur when you give local anesthesia. Okay, immediately after local anesthesia, you might see this anaphylactic shock. Okay, then you might, the latex which is present in the gloves can cause anaphylactic shock, and some of the drugs like penicillins, some people are allergic to these. Okay, so they cause anaphylactic shock. Okay, so what you should remember in anaphylactic shock is the definition and how it is to be treated and how it is been formed. Okay, the physiological process, how this shock can occur. Okay, so that is what you should remember. So before I go to the anaphylactic shock, which is formed by the humoral immunity, you should be knowing immunity, because I'm dealing only one part of the question. Okay, so several questions are asked, but not frequently asked. Okay, so immunity can be asked for you people. What the definition of immunity? Classify immunity. Okay, so the definition of the immunity is ability of the body to resist pathogen, abnormal cells or toxins that are potentially damaging to our body. Okay, so it can be innate or acquired. Innate is inborn. Okay, So inborn is specific, that is the specific cells like natural killer cells, they are going to provide immunity, or non-specific like tears, sweat. Okay, they are going to protect our body. Okay, so these are the innate inborn ability to resist the pathogens, whereas acquired immunity is when we are exposed to the toxins or when we are exposed to that antigen. Okay, so this acquired immunity is of two types, humoral and cell mediated immunity. Humoral immunity is the one that is going to produce the anaphylactic shock or type 1 hypersensitivity, okay, reactions. Okay, so how does this humoral immunity process is formed? The first is the antigen presentation. Whenever we are exposed to antigen, just now I told you anaphylactic shock could be the allergic reaction when we are exposed to that antigen, like gloves, latex particles, and the local anesthetics. So whenever this B cells recognizes this, how it is going to process it? Okay, so the antigen processing and presentation is done by B lymphocytes in humoral immunity, whereas T lymphocytes get activated by antigen presenting cells like macrophages, dendritic cells. Okay, so T lymphocyte is left side, what you are seeing in the slide, and the B lymphocyte activation is to the right side. So I'll be concentrating on the humoral immunity, how this B cell is going to produce the immunity. Okay, so first is the antigen processing and presentation. It is presenting to the B lymphocytes in order to produce the next activation. The B cells gets activated in order to produce antibodies. So what is these antibodies? How they are formed? They are formed whenever the B cells are activated, when they are exposed to the antigen. So the antibodies which are produced are the B lymphocytes, are memory B cells and the plasma cells. Antibodies are produced by these plasma cells. Okay, so these plasma cells, the antibody production will in turn is going to kill the antigen, okay, exposed allergen, by direct attacking them. Okay, so antigen antibody reaction by neutralizing, precipitating, or by complement fixation. What is this complement? The C proteins which I discussed later, okay, previously. Okay, so that is the complement proteins. Okay, so now the antibodies have been produced. What they do? These antibodies, that is the IgE type for type 1 hypersensitivity reaction, they are going to bind to the mast cells which are present in our body, and that is going to release histamine, and the leaked histamine into the blood is going to affect the multiple organs and cause the reactions. The reactions what you are going to see in anaphylactic shock. This is all about the inflammation and the anaphylactic reaction which is formed by humoral immunity. Okay. The types of other shocks would be hypovolemic shock because of blood loss, bleeding. Excessive bleeding can cause hypovolemic shock. The cardiogenic shock is due to the weakened heart. Okay, so cardiac failure can cause the cardiogenic shock. Neurogenic shock is any trauma to the nerve. Okay, so that can cause the shock. Anaphylactic shock is just now saw the exposure to allergens, and the septic shock. Okay, septic shock is the end stage where majority of the multi-organ failure can occur because of the bacteria, okay, which is involving whole of the body. Okay, so these are the different types of shock. So what you need to know whenever you see such shock, the most important is anaphylactic shock. As I told you, it is the binding of foreign antigens. Okay, so when the antigen bind to the histamine, they are going to bind to the mast cells, they are going to release histamine. Okay, so this histamine is going to cause various reactions in the body like bronchospasm, laryngeal edema, and respiratory distress, and cause massive vasodilatation. So the thing what you need to know because of all these consequences is you should know the treatment of shock, immediate emergency, what you are going to do. So you have to go monitor the pulse rate, see for the turgidity of the skin, and check for the BP if there is any low BP. Okay, so all this should be checked, and immediately the person should be transformed in this position, the head low and leg up position, so that the brain doesn't be divided of the blood loss, whatever has been occurred. Okay, so vasodilatation. Because of this vasodilatation, there is no pressure for the blood, for the propulsion of blood to reach the brain. So there will be less blood supply to the brain. So you need to do head down and leg up position, and immediate IV body fluids has to be transferred. Okay, so this is all about shock, you should be knowing. Then they might ask you the pain pathway. Okay, so commonly encountered this one symptom, what the patient comes for is pain. So you should be knowing completely about the pain pathway, how the nerve is going to carry the pain to the cortex, and the pain is perceived by the body. Okay, so this is what you should be knowing in pain. So pain is carried by lateral spinothalamic tract. You should be knowing the pathway properly, the diagram. Okay, so you need to draw a very good diagram showing the neurons, synapse. Okay, where does this synapse, the first order neuron, second order neuron, origin, course, and termination. Okay, so the origin is brought about by free nerve endings, A delta fibers and C fibers. A delta fibers is for fast spread, pricking type of pain. Immediate pricking type of pain is caused by A delta fibers, whereas the slow pain, dull aching pain is caused by C fibers. Okay, this is the origin. So where they take up, the fibers of A delta and C fibers go to the spinal cord in the dorsal horn. They reach the dorsal horn. They don't enter the ventral horn. They reach the dorsal horn. Ventral horn is for motor. Okay, so the dorsal horn is for the sensory. Okay, so it reached the dorsal horn and synapse with another neuron. This is the second order neuron. Okay, so they cross the midline and run on the opposite side of the spinal cord. Okay, straight until thalamus. Okay, the second order neuron arises in the spinal cord, but it has a long route. Okay, so course, and they reach the thalamus, and in the thalamus they relay in ventroposterolateral nucleus of thalamus to another neuron. This is called the third order neuron. This third order neuron then relays in the parietal cortex of the brain. Okay, so area number 312. This is somatosensory area that is going to sense and perceive the pain. So there are three order neurons. So you are seeing two pathways. One is in the green, another one is in the yellow. The green one is A delta fibers, which is carrying the fast pain, whereas the yellow pathway is the slow pathway or the slow pain. Okay, dull aching pain. So they are rightly named as neospinothalamic tract and paleospinothalamic tract. Okay, you can see here, neospinothalamic tract is reaching the thalamus without any collaterals, whereas paleospinothalamic tract, lateral spinothalamic tract is showing the collaterals to reticular formation, periaqueductal gray matter, and hypothalamus, because this is carrying the slow pain. The dull aching pain is also involved in emotions. Okay, the heart rate is going to increase, emotions and autonomic disturbances. So it relates to all these areas in order to show other emotional component of the pain. Okay, so the dull aching pain gives collateral, whereas the fast aching pain pathway doesn't show any collaterals because emotions are not much involved in the fast pain. Okay, so this is what you should remember in lateral spinothalamic tract and the one which is carrying fast pain, the one which is carrying slow pain. So this is a simple flow chart. I'll be sharing this slide so that you'll remember what to write in the pain pathway. For this is the fast pain which is carried by the A delta fibers. Okay, So it is going to relay in the lamina 1 and 5 of the spinal cord, crosses the midline and relay synapses with the second order neuron, passes through spinal lemniscus, ventroposterior lateral nucleus of thalamus, from there to the somatosensory area. This is fast pain. This is slow pain flowchart, what you can remember. Pain receptor, that is the C fibers, nociceptors. These are called nociceptors. They relay in 1, 2, and 5 region of the posterior portion of the spinal cord. They cross the midline, synapse with the second order neuron. Then they show the collaterals to these areas. They run in the PPL and BPM nucleus of thalamus and reach the parietal cortex. So this is the pain pathway. So along with pain pathway, I have noticed some other things which is asked in pain. That is control. Okay, pain separation mechanism. Okay, so before I deal with the pain separation, one more pathway you should remember is the pain with what are the pain sensation carried by the face region, because dental, as you all know, you are dealing with the face region. So the face region is the pain pathway carriage is done by trigeminal pathway. Okay, so trigeminal pathway is the 5th cranial nerve. It has got 3 divisions: ophthalmic division, maxillary division, and mandibular division. This diagram you can easily draw for trigeminal pathway. So from all these 3 divisions, the pain is carried, and it is going to not relay here. It forms a ganglion in the trigeminal nuclei. Then it runs in the medulla, pons, and midbrain to reach 3 to 1. Okay, area number 3 to 1. Okay, the spinal trigeminal pain pathway is the one that is going to carry the pain. Other areas where it is going to relay, the mesencephalic neurons and the chief neurons, they are going to sense the touch sensation, other sensory components. The pain carriage by the face is done by the spinal trigeminal nucleus. Okay, the pain and temperature. Okay, so this is going to carry the pain. This is about the trigeminal pathway. And as I was telling, pain separation, gate control mechanism. Okay, so this is also been asked, how the pain separation physiologically can take place. Okay, so the gate control pathway or the mechanism was proposed by Medzack and Val in the year 1965. So what they proposed, what is this theory? So non-painful stimulus can block the painful stimulus. So that is what mother used to do, you know, whenever we used to fall. Mother used to rub around that area where we had fall. Okay, that rubbing will in turn suppress the pain. So that they observed, Medzack and Ball observed this, and how this pain suppression is occurring because of rubbing. So that is what is the basis for pain gate control theory. So what they tell is a gate exists in the dorsal gray horn of the spinal cord that modulates this pain. Okay, so an interneuron is present in this area. Dorsal horn is here. An interneuron. This neuron is going to suppress that pain. Okay, it is either going to open the gate or close the gate, which will tell us whether there is pain or no. So what is this mechanism? There is an inhibitory interneuron which is always present in the dorsal gray horn, which is going to inhibit the pain carriage to the cortex. Okay, that is tonically active. Tonically means it is always active. Okay, so but whenever we experience pain, what happens is the pain fibers, it is going to inhibit this inhibitory neuron. So when this inhibitory inhibition is stopped, then there is strong stimulation of this and causes pain. Okay, so then we say that gate is open. Okay, but when we rub around that pain area, that A beta fibers, it's not A delta. Remember, A delta is for pain. A beta fibers, the rubbing, the touch fibers, they are going to stimulate this inhibitory interneuron so that the pain going to the cortex reaches less. Okay, so that time we tell that gate is closed. This is known as gate control pathway of pain suppression. Okay, so now coming to the salivary secretion, most frequently asked question even in UG days as well as now for you people also. Okay, so as you all know, saliva is most important in the oral this thing for maintaining the good health of the teeth and gums. Okay, so the three glands, parotid gland, submandibular gland, and the sublingual glands, they are going to produce saliva. Okay, so what is the type of question they might ask you in saliva is composition and functions of saliva, how saliva is going to buffer the acid in the mouth, and the regulation of saliva. These are the frequently asked questions in the salivary secretion. So the composition, what is this saliva containing? Okay, so 99% water. Okay, so saliva, as you all know, it is made up of water, and solids are 1%. Out of these solids, the enzymes, what are the enzymes? Ptyalin and salivary amylase. They are going to digest the food. The immediate exposure of the mouth is food and water. Is it not? So these are going to be digested initially by these enzymes. Okay, lysozymes are going to destroy the bacteria, and lingual lipase is meant for digestion. Okay, so other components would be kallikrein. Kallikrein, as you all know, just now saw, it helps in blood coagulation. So whenever there is wound, what you do, you are going to place your saliva there, right? Sometimes in the olden days and all, they used to suck the blood, so that the saliva there, it is going to stop the bleeding. Okay, it contains blood group antigens, A, B, O blood group. It contains urea, uric acid. That means saliva has a role in excretion of these waste materials. We spit saliva, so in the form of spitting, we are going to excrete these. It contains the mucin and IgA. IgA is meant for immunity. Mucin and proline-rich protein, they act as a buffer system. Okay, so saliva, the mouth is the area where it is exposed to numerous bacteria. These numerous bacteria are going to digest the food and release acid. So as far as possible, this acid should be made less. Okay, the mucin and the proline-rich proteins, they are going to buffer the acid which is present in the mouth. Okay, so that is going to reduce the acid level in the blood, in the saliva. Okay, so if there is acid level in the saliva is more, then it is going to damage the teeth. Okay, enamel, it's going to damage the enamel and cause caries. Okay, so these are the things you should be remembering in the saliva. And it contains other electrolytes like chlorine, sodium, bicarbonate, potassium. Okay, so it's the bicarbonate and potassium level that is going to maintain the pH to 6 to 7.4. That is in towards alkaline side. Okay, so this is the composition of saliva, and the functions of saliva is protection. Okay, it protects the teeth and gums. Okay, then it helps in the preparation of food for swallowing, easy swallowing of the food. Then initiation of the carbohydrate digestion because of the presence of enzymes. It helps in taste sensation. If it is not dipped in saliva, then we don't have that pleasure of feeling that taste. Okay, then it helps in speech. If the mouth is dry, then it's highly difficult for us to speech in another 1 hour. Even we'll be feeling the same thing. Almost all professors feel this. Then it helps in buffering the acid in the mouth. As I told you, the buffering action is done by mucin and proline-rich proteins. They are going to help in the buffering action of the acid, which is formed by the bacterial action of the food in the mouth. Okay. Then it helps in excretory function. It excretes the waste materials. Then it helps in the water maintenance of water balance. And most important is temperature regulation. It helps in temperature regulation, but this temperature regulation is most important in lower animals. You must be seeing the dog, if it runs, it's going to put its tongue outside, so that the temperature regulation is brought about. So these are the composition and functions of saliva. So almost all I have covered, and one more thing you should be knowing is regulation of salivary secretion. Okay, so regulation of salivary secretion is brought about by autonomic nervous system, sympathetic and parasympathetic. Both are going to stimulate the secretion of saliva, whereas parasympathetic is important for the thin secretion of saliva, excessive secretion of saliva. Okay, so how does this parasympathetic nerve is going to get stimulated? Conditioning. Conditioning is Pavlov's experiment you might be knowing. Okay, whenever the bell rang, the dog didn't salivate, but when the food was exposed, the dog salivated. So what did this Pavlov did is, whenever he put the food, he rang the bell. So the next time when the bell was rang, the dog started salivating, right? So that is conditioning. It is conditioned that whenever the bell rang, it is going to get exposed with the food. Okay, so it remembered in that way. So that conditioning will cause the salivary secretion. So at 1 o'clock, you start, your gastric secretion is going to increase, your mouth starts watering in so that you will have lunch. Okay, so this is what is known as conditioning. Then food, presence of food can cause increased secretion of stimulate parasympathetic and cause increased secretion of saliva. Smell of the food, nausea, that means before you vomit, you might see your body, your mouth getting salivated more. So all these are going to stimulate parasympathetic nerve, and cranial nerve 7 and 9 are going to carry and release acetylcholine. And this acetylcholine acts on the ductal cells of the salivary glands to secrete saliva through second messenger system, that is IP3 and calcium. This is the parasympathetic nervous system. Sympathetic is by T1 and T3, which causes the copious secretion of saliva. Okay, so this is how the regulation of saliva takes place. So coming to the last one, that is the calcium. The serum normal calcium level, that is 9 to 11 milligram per deciliter. So in so far, what all you have seen, it's a normal regulation. So this calcium is regulation is most important. The maintenance of this 9 to 11 milligram is most important, because it might cause emergency situation, just like anaphylactic shock, if this level is not maintained. So you should be knowing how this calcium ECF, extracellular content of calcium 9 to 11 milligram per deciliter of the blood is maintained. Okay, so the normal calcium level, whenever we tell regulation, you should know the normal content. It is 9 to 11 milligram per deciliter. It should not go less than 9. It may cause some emergency situations. So what are those commonly, frequently asked questions for you people? How calcium is regulated, or blood homeostasis of calcium is brought about. Okay, so the regulation of calcium is mainly brought about by 3 hormones. Calcitriol, okay, which is nothing but activated vitamin D3. Okay, so active form of vitamin D3 is called calcitriol. Then PTH, PTH is nothing but parathormone. Then calcitonin. These 3 hormones act on 3 organs. What are those 3 organs? Kidney, bone, and GI. Okay, so act on these 3 hormones in order to maintain blood calcium level. How does they do that? Okay, so as you all know, I told you it is 9 to 11 milligram per deciliter is the normal calcium level. Okay, so whenever there is fall in the blood calcium level, what happens? The parathormone is secreted. Parathormone will in turn mobilize calcium from the bone and absorb calcium from the kidney as well as GIT with the help of activated vitamin D3, and increases blood calcium level, brings back the blood calcium level to normal. But if this calcium level is increased more than 11 milligram, so what happens? The calcitonin, which is present in the thyroid gland, okay, they are going to get released, and what in turn they do? They stimulate, deposits calcium in the bone and decreases reabsorption of calcium from the kidney and brings back the blood calcium level to normal by reducing the blood calcium level, because calcium is getting deposited here. Okay, so this is how the blood calcium. So The vitamin D3 and parathormone helps in increasing the blood calcium level, whereas calcitonin helps in decreasing the blood calcium level. So these three hormones, calcitonin, vitamin D3, activated vitamin D3, and the parathormone, they three together maintain the blood calcium level. So what happens? What is the emergency situation which I was talking about? It is the hypoparathyroidism. That means parathormone is not working properly. If parathormone is not working properly, it will in turn causes decreased production of activated vitamin D3. So both the vitamin D3 action and parathormone is hindered. So what will happen? What will happen to blood calcium level? It will decline. Okay, so it will be less than that. So what the feature what we see in hyperparathyroidism is tetany. Usually asked question. What is tetany? Okay, so it's a clinical syndrome as a consequence of hyperparathyroidism, which will lead on to decreased blood calcium level. So what are the signs you are going to see? You see Schwartz-Tech sign. There will be carpopedal spasm. Then Trozius sign, laryngospasm will be there. Hypocalcemia because blood calcium level, but hyperphosphatemia. Phosphate level will be more in the blood. Okay, the normal ratio of calcium and phosphate has to be maintained in order to give strength to the bone. Okay, so that is altered. Okay, so what are these Schwartz-Tech sign, carpopedal spasm, and Trozius sign? Schwartz-Tech sign is if you tap the facial nerve just in front of the ear, sudden twitching of the face is seen. Okay, in case of hypocalcemia. Okay, and there will be carpopedal. You might have noticed carpopedal spasm in yours also. Sometimes your hands gets twisted off like this, and it remains in this contracted state, and it will be very painful. Okay, so that is due to hypocalcemia. Okay, then you are going to see Trozius sign. Trozius sign is you can elicit this carpopedal spasm if you apply pressure through BP cuff. If you apply the BP cuff and raise the pressure in the BP cuff, you're going to see this carpopedal spasm. This is known as latent tetany. That is, it is not clinically evident tetany, but latent. There is every chances of that person going into hypoparathyroidism. Okay, so that is known as Trozius sign. Schwartz-Tech sign is tapping the facial nerve and eliciting the facial twitching. Okay, because of hypocalcemia. So this is due to less calcium level. Okay, laryngospasm, as you all know, it causes decreased word output. Okay, hypocalcemia and hypercalcemia. These are the features of calcium. Okay, so this completes my talk on various questions which been asked. These are the sample questions. What are the frequently asked questions? I didn't touch the importance of blood group in these are the sample questions from Karnataka. Okay, so I didn't touch blood group. As you all know, blood group is most important for blood transfusion if there is any emergency. So you read about this. I didn't touch about the pernicious anemia. Pernicious anemia is nothing but the vitamin B12 deficiency anemia. So I told you about the factors affecting anemia. Syncope and its management I didn't touch, and regulation of body temperature I was unable to cover up. Okay, so I think syncope and its management pathology people can highlight on this. Then anaphylactic, all these most of them I have covered, and these are the sample questions covered in Kerala. Okay, so again syncope, and these are not frequently asked questions. 1 or 2 year they have asked, that's it. But majority of the topics what I have covered is frequently asked questions. Okay, so these are the types of questions they might be asking you people. This is from the MGR University. Okay, so most of them are frequently asked questions which I have covered in today's class. Here also you can see in Madhya Pradesh, the question was asked on pulse, respiratory, BP and all that. Okay, So this is only once asked, not frequently asked. So hence I could not cover up these things. Okay. So these are the questions, frequently asked questions. And in physiology, students remember that you need to write the definition, the flow chart, the process, the diagrams, okay, involved in those things. So this was my presentation, brief presentation on physiology. What are the things you should write for the frequently asked questions so far they have asked in your papers. Thank you all.
Thank you, ma'am,
Thank you, ma'am.
for
Yes.
the insightful presentation, ma'am. Are there any questions?
No, ma'am.
No questions on physiology?
No, ma'am.
So I would like to give in my input. Students,
Yes.
please go and learn the diagrams and the flow charts for all the processes. That actually saves a lot of your time and makes things easier for the examiner who's, correcting your papers to understand that you have read well.
Okay, thank you for giving me this opportunity to present about physiology. Thank you very much, organizers. Thank you, students.
Thank you, ma'am. Thank you for your wonderful presentation.
Kindly present the certificate for madam.
Okay, ma'am.
Thank you so much.
Kindly accept this certificate as a token of gratitude and appreciation for your valuable presence and insightful session. Once again, thank you, ma'am.
Thank you so much.
Okay, now continuing with today's academic session, it's a great honor to introduce Dr. Arun Mamachan Xavier, Professor in the Department of Pediatric and Preventive Dentistry at Amrita School of Dentistry, Kochi. Dr. Arun has made remarkable contribution to academics, research, and clinical pediatric dentistry. He is the recipient of several prestigious recognition, including the Bright Smile Bright Future Award by IAPD, Young Periodontist Research Award, and Academician of the Year. He has authored more than 70 scientific publications and contributed to specialty textbook. We warmly welcome you, sir. Over to you, sir.
Thank you so much. Thank you so much.
Thank you. You sound like.
Can I have my lecture played?
Yeah, she's
Okay,
doing
sir.
it.
Thank you. Thank you so much. We could thank the organizers of Good afternoon, one and all. I welcome each one of you to my rapid revision lecture on pathology. Before I begin, may I take a moment to thank the organizers of the Royal Dental College, especially Dr. Anjana ma'am, for inviting me to deliver this lecture today. I most sincerely also thank the ISPPD head office, Dr. Sudhindra Balika sir, our president, Dr. Varinder Goyal sir, the honorable secretary, and the ISPPD office bearers for your trust and support always. Over to my presentation. Being a rapid review and that conducted nationally for the first time in basic sciences subjects in the association, it was indeed a Herculean task to carefully go through as many university basic science question papers over the past 10 to 20 years and collect all those pathology questions that have appeared, so that it could be turned out to be easy for you to identify which are important and which are least important. I have collected all exam questions for each major topic, organized their various forms into single slides to show how that topic can be asked. But due to time constraints in this presentation, I am forced to give you either a flow chart, it's important and not miss diagrams, management sequence, or its dental applications. So one of the major topic is inflammation, and it has appeared as define inflammation, list the types, stages, and mediators, describe the process of acute inflammation, define chronic inflammation, and discuss the events of inflammation, inflammation, stages of inflammation, events associated with inflammation. The flow chart would be beginning with the types of inflammation, followed by its cardinal signs, and progressing through the stages of acute inflammation, the role of chemical mediators, chronic inflammation, and its outcomes. Do not forget to state clearly that acute inflammation occurs through sequential vascular and cellular events, where vascular changes increase the blood flow and permeability, followed by leukocyte migration, phagocytosis, and microbial killing at the site of injury. A note this figure depicting the vascular and cellular changes that occur during acute inflammation should be there in your answer sheet. A figure that shows the events following injury is definitely highly appreciated. It should give an impression to the examiner that you know that vasodilation and increased vascular permeability causes redness, heat, and swelling, while leukocytes undergo margination, rolling, adhesion, and migration to reach the site of injury and eliminate pathogens, as you see in these figures here. A table highlighting the key chemical mediators of acute inflammation, such as histamine, prostaglandins, cytokines, and bradykinin, which regulate vascular changes, leukocyte recruitment, fever, pain, and tissue injury, will fetch you more marks definitely. A figure on the outcomes of acute inflammation, including the complete resolution, progression to chronic inflammation, abscess formation, or healing by fibrosis and scar formation, depending on the extent of tissue damage, is definitely worth mentioning. The figure that explains the progress of chronic inflammation, where persistent injury leads to continuous immune cell infiltration, tissue destruction, and eventual fibrosis with scar formation, can be represented as the table shown here. A figure summarizing the possible outcomes of inflammation and a table highlighting the key differences between acute and chronic inflammation in terms of duration, cellular response, tissue damage, and healing will definitely fetch you more marks. The next major topic is chemical mediators of inflammation. And the questions have appeared as write short notes on chemical mediators of inflammation or chemical mediators of inflammation. Explain the chemical mediators of inflammation. Elaborate on chemical mediators of inflammation and add a note on healing of the extraction socket, and also appeared as inflammation and its chemical mediation. I have provided a content flowchart and key figures to this question here. It basically provides an overview of chemical mediators of inflammation, including their classification into plasma-derived and cell-derived mediators and their major roles in the inflammatory response. In chemical mediators of inflammation, you also need to illustrate the metabolism of arachidonic acid and highlight the key differences between exudate and transudate in inflammation. Kindly also make a note of the references with the tables and figures given in each of these slides, which will definitely be important for you. A schematic diagram illustrating the activation of the complement system through the classical and alternative pathway, as you see here, and their role in inflammation is worth adding to your answer. As we are all aware, The generated complement components promote vasodilation, increase vascular permeability, chemotaxis, and forms a membrane that attacks the complex and causes cell lysis. The next major question is vascular events and the changes in inflammation. The questions have appeared as: discuss briefly the vascular events of inflammation, or chemical mediators of inflammation and vascular events of inflammation, or vascular changes in inflammation, vascular events involved in inflammation, vascular events of inflammation. Explain the vascular events of inflammation. These vascular events are the hallmark of acute inflammation, beginning with the transient vasoconstriction followed by vasodilation, increased vascular permeability, and vascular stasis. Mediators such as histamine, prostaglandins, nitric oxide, and serotonin contribute to these changes, resulting in redness, warmth, swelling, and slowed blood flow. I strongly recommend these figures to your answer for getting higher scores. The next major question is general wound healing. The questions have appeared as: wound healing and repair, discuss healing of wounds and factors that delay healing of wounds, write in detail about the mechanism of healing, define repair, describe the process of healing of a surgical wound, discuss the mechanism of repair of tissues, discuss the process of healing of surgical wound, healing of a surgical wound healing. I strongly recommend you follow a content flow chart like this to approach this answer. It basically outlines the process of wound healing and repair, including the phases of hemostasis, inflammation, proliferation, and remodeling. It also highlights the mechanisms involved in tissue regeneration, granulation tissue formation, angiogenesis, collagen deposition, and the factors that affect wound healing. A figure that illustrates the process of angiogenesis, where new blood vessels are formed from existing vessels through endothelial cell proliferation, migration, and maturation, is essential to increase the weight to your answer. You are also benefited if you provide a table highlighting the difference between regeneration, which is nothing but restoration of the original tissue structure and function, and healing, which often results in scar tissue formation. So please include them in your answer. If you talk about wound healing and its significance in dentistry, well, delayed healing in dentistry can lead to complications such as dry socket, infection, wound dehiscence, excessive scarring, and osteomyelitis. These complications can be prevented and managed through proper infection control, gentle tissue handling, adequate suturing, good oral hygiene, and regular follow-up care. So please provide a content checklist with these items listed in your answer to get the maximum marks. The next major question on factors affecting wound healing. Well, wound healing is influenced by both local factors as well as systemic factors. And the local factors include infection, blood supply, foreign bodies, and mechanical stress, while the systemic factors include nutrition, diabetes, age, and immunosuppression. So these factors can delay healing and can lead to poor scar formation if not properly managed. So please provide an illustration like this when you approach this answer. Talking about the types of wound healing occurs by two mechanisms: primary intention and secondary intention. Primary intention occurs in clean wounds with minimum tissue loss and rapid healing, whereas secondary intention occurs in larger wounds with significant tissue loss involving granulation tissue formation and wound contraction. Kindly note the points in the table provided here for answering this question in your exam. The content flowchart that is given here compares the sequence of events in the three types of wound healing. Primary, that is the first, secondary, which is second, and tertiary, that is the third or delayed intention. Primary intention rapidly heals with minimum scarring, while secondary intention heals slowly with significant tissue loss and scarring, while tertiary intention involves delayed closure of contaminated wound after the infection is controlled. So kindly note that any question on wound healing should have these flowcharts. This is a figure illustration on the stages of healing by primary and secondary intention over time. Primary intention involves closely opposed wound edges with minimum scarring, as you see here, whereas secondary intention involves greater tissue loss, as I just mentioned, abundant granulation tissue formation, wound contraction, and a large scar. Adding figures, as you all know, adds more weightage, so definitely act appropriately. The next major question that has appeared for exams is the extraction socket or the extraction wound healing. So the questions have appeared as: write about healing of tooth socket following dental extraction, post-extraction healing of a socket, healing of tooth socket after extraction, post-extraction wound healing following extraction, healing of extraction wounds, healing of extraction wound, explain causes, clinical features, and management of dry socket. Write a short note on bone changes after extraction of tooth. So these are schematic skeletons to approach this answer. It shows the stages of healing of a tooth extraction socket, beginning with the blood clot formation and progressing through granulation tissue formation, bone deposition, and remodeling until the complete healing occurs. I have also put a schematic representation of the post-extraction bone changes and development of dry socket, which is nothing but a painful complication caused by the loss of blood clot and exposure of the underlying bone. So you may use each one of them appropriately for the question that comes for your exam. The next major question is shock. Define shock and classify it. Write the pathogenesis of circulatory shock. Write a short note on shock and its types. Describe the pathophysiology of shock. Explain the etiology and pathophysiology of shock. Shock alone. Types of shock that can be encountered in pediatric dental clinic. Hemorrhagic shock. Pathophysiology of circulatory shock and its management in a dental setup. Discuss the pathophysiology changes in body after acute blood loss. So let's see how to approach this answer. After a brief introduction on shock, which is nothing but a life-threatening condition, as I just mentioned, caused by inadequate tissue perfusion and oxygen delivery, this can be then followed by a content flow chart, which shows that reduced cardiac output or blood volume leads to hypotension and tissue hypoxia, which can be reversible with timely treatment. But maybe it may progress to irreversible injury as well, and sometimes death if untreated. So from these points, key points, you can build up your answer and gain your marks. Having a table that summarizes the major types of shock like hypovolemic, cardiogenic, septic, neurogenic, and anaphylactic shock, along with their causes and clinical examples, is definitely noteworthy. A schematic representation that explains the pathogenesis of cardiogenic and hypovolemic shock, where reduced cardiac output or blood volume leads to decreased tissue perfusion, hypoxia, and oxygen dysfunction, adds more weightage to your answer definitely. If cardiogenic or hypovolemic shock is asked, please use these tables that are shown here. Here, the figure illustrates the pathogenesis of septic shock, where microbial toxins trigger an excessive inflammatory response leading to vasodilation, endothelial injury, impaired tissue perfusion, and multi-organ failure. Lipopolysaccharides in turn activate these macrophages and endothelial cells to release cytokines such as TNF, interleukin-1, and interleukin-6, which contribute to hypotension and shock. So definitely use these illustrations appropriately if septic shock is your question. Shock, as you all know, is a life-threatening emergency that can occur during dental procedure and requires immediate recognition and prompt management. In dentistry, prevention through careful patient assessment and emergency preparedness is essential to reduce the risk of serious complications and improve the patient outcomes. So kindly incorporate a flow chart which is similar to what I have put here while approaching this answer on shock in dental settings. The next major question is anaphylaxis or anaphylactic shock. It appears as anaphylaxis, anaphylactic shock. Write the causes and symptoms of anaphylactic reaction. Write the management protocol of anaphylaxis in dental practice. Management of anaphylaxis in a pediatric patient. Classify allergic reactions and write in detail about the anaphylactic shock and its management. I have provided an overall content flow chart while approaching this answer on anaphylaxis or associated shock. So as we are all aware, anaphylaxis is a type 1 hypersensitivity reaction caused by allergens such as drugs, foods, latex, or sometimes insect stings, which leads to the release of mediators like histamine that cause vasodilation, bronchospasm, and edema. So early recognition and prompt treatment with intramuscular adrenaline, oxygen, airway support, and intravenous fluids are critical to prevent life-threatening anaphylactic shock. So I would suggest that you build up from this flowchart that is provided here. As we are all aware, anaphylaxis is also a medical emergency that can occur suddenly during dental treatment and may progress to airway obstruction and life-threatening shock. So prompt management with intramuscular adrenaline, oxygen, airway support, and careful monitoring is essential, while prevention relies on thorough medical and allergy history assessment. So kindly incorporate all these salient points as a flow chart that is listed here. So while approaching this answer on anaphylaxis in dental settings. The next major question is bleeding disorders or coagulation disorders. So the questions have appeared as enumerate coagulation disorders and its pathophysiology, blood coagulation and bleeding disorders in pediatric dentistry, clinical importance of bleeding disorders in pediatric dentistry, discuss the pathophysiology of bleeding disorders in children, bleeding disorders in a child and its management, write a short note on bleeding disorders, factors regulating clotting, write a short note on bleeding time and clotting time, define hemorrhage, classify it, describe the management of secondary hemorrhage from an extraction socket. So I have prepared a content flowchart to broadly approach any question on bleeding disorders or coagulation disorders or hemorrhage and their management in pediatric dentistry. So basically it outlines the concept of hemostasis and bleeding disorders, including their classification, clinical features and investigations in children. So your answer should also highlight the importance of managing bleeding risks during dental procedures through careful preoperative, intraoperative, and postoperative care. Bleeding disorders are highly significant in dentistry because they can lead to excessive bleeding during procedures, delayed hemostasis, and complications after oral surgery. So careful patient evaluation, correction of coagulation defects, and the use of local hemostatic measures are essential for safe dental management. So kindly incorporate a flowchart which is similar to this while approaching this answer on bleeding disorders in dental settings so as to get the maximum marks. So these are other important and not missed tables in the section of bleeding disorders. So the first table here on the left-hand side classifies disorders of hemostasis into vascular disorders, platelet disorders, coagulation factor deficiencies, and thrombotic disorders. And the second illustration on the right-hand side is on the normal hemostatic process and shows how defects in the blood vessels, platelets, or clotting factors can lead to abnormal bleeding. So kindly use them appropriately based on the question asked. Certain add-on illustrations and tables are required to build on your answer appropriately. So the first one is the intrinsic, extrinsic, and common coagulation pathway and the laboratory tests which are used to assess them, such as PT and APTT. So I have also added a table here on the right-hand side on the common causes of purpura and the important screening investigations used to diagnose hemorrhagic disorders, which may appear as independent paper or viva questions. This is also an illustration on platelet disorders, which may result from decreased platelet production, abnormal splenic pooling, or increased platelet destruction, leading to thrombocytopenia. So platelet disorders are basically classified into quantitative defects affecting platelet number and qualitative defects affecting platelet function, both of which can increase the risk of bleeding. I suggest that you use them appropriately when a question is asked on platelet dysfunction. The next major question or repeated question is hemophilia. So questions have appeared as classify hemophilia, write in detail about its management. Hemophilia, classification and management, write a short note on hemophilia or hemophilia alone, a broad topic. So this is a content flowchart to approach this answer. It basically provides an overview of hemophilia and inherited bleeding disorder caused by deficiencies in clotting factors of the intrinsic coagulation pathway, leading to prolonged bleeding and recurrent hemorrhages. It also, this flowchart outlines the diagnosis, treatment options such as factor replacement therapy and the important dental management considerations before, during, and after treatment. So build your answer from this flowchart and definitely you will definitely give a good impression to the exam. If you also add an illustration depicting the X-linked recessive inheritance pattern of hemophilia, where affected males pass the defective gene to all the daughters as carriers, while sons are usually unaffected, the answer will definitely carry more weightage. Briefly also highlight the importance of recognizing bleeding disorders in dental practice, as patients may experience prolonged bleeding after procedures and require specialized management. This is a table that compares the laboratory findings in hemophilia A, hemophilia B, and von Willebrand disease, highlighting the differences in the clotting factor levels and the coagulation tests. So use this table also to build up on your answer. The next major or repeated question is either thrombosis or embolism. The questions have appeared as: describe the factors that predispose to intravascular thrombosis. Describe the fate of thrombus. Describe the mechanism of thrombus formation. Define thrombosis. Discuss the pathogenesis of thrombosis formation. Write a short note on Virchow's triad. Define and classify embolus. And write a short note on fat embolism. So the first is a schematic representation on the left-hand side of thrombosis. So thrombosis is nothing again but the pathological formation of a blood clot within the blood vessels. So the flow chart over here outlines its classification, pathogenesis, morphology, and its complications. Adjacent to this on the right-hand side is a figure that depicts the Virchow's triad, which is a very, very important aspect, which is nothing which has endothelial injury, abnormal blood flow, and hypercoagulability, which are the three major factors which are responsible for thrombus formation in the body. So please do not miss these points when you answer the question on thrombus formation. This is another table that outlines the major inherited and acquired causes of hypercoagulable states, which increase the risk of abnormal clot formation and thrombosis. The adjacent figure on the right-hand side illustrates the possible fates of a thrombus, including dissolution, propagation, embolization, organization, and recanalization, each of which is important and are clinical consequences. So please use this representation appropriately for the question and for which the marks are concerned. This table reviews the coagulation pathway and compares the arterial and venous thrombi based on their causes, composition, and sites of occurrence, which is very, very important. And the adjacent figure on the right side illustrates the pathogenesis of thrombus formation, where endothelial injury leads to platelet adhesion, aggregation, and fibrin deposition, resulting in clot formation. So please do not forget to add them when thrombosis is asked. This content flow chart is specific for embolism. It basically introduces embolism, particularly fat embolism, where fat globules enter the circulation and obstruct the blood vessels, potentially leading to serious complications. If paradoxical embolism is the question, mention it as an embolus that crosses a cardiac septal defect and enters the systemic circulation, causing infarction in distant organs. It would be ideal to represent it with a figure like that is represented here on the right-hand side. This is a schematic representation of the pathogenesis of fat embolism syndrome, where fat globules obstruct the microcirculation and cause endothelial injury, leading to respiratory and neurological complications. If saddle embolism is a question, a viva question also, mention it as a large embolus that is lodged at the bifurcation of the pulmonary artery, which can cause massive pulmonary obstruction and sudden death. So it would be ideal to always represent it with figures as shown here. The next major question or repeated question is on pulpal pathology. The questions may appear as: what is inflammation? How do you attribute it to the dentopulpal system? Or how and why is the reaction of the pulpal connective tissue to injury different from that of the connective tissue elsewhere in the body? Discuss in detail the pathophysiology of pulp, etiology, pathogenesis, progression of pulpal infections, degenerative changes of pulp. Here, I provide you with an overview on how to approach the answer on inflammation and pulpal pathology, including the causes, pathogenesis, and cellular changes that occur during pulpitis. You can include the progression from reversible and irreversible pulpitis to pulpal necrosis and periapical lesions, along with various degenerative changes that can affect the dental pulp. You may build up from this flowchart and answer appropriately to the question asked. The next repeated question is on dental caries. Discuss the caries model. Discuss the current concepts in microbiology and pathology in dental caries. So I know the question is very, very familiar to all of us. However, I have provided an overview of the content of dental caries pathology question. So it should highlight the interaction between host factors, microorganisms, dental plaque, diet, and time in the development of the disease, as you all know. You may also introduce various caries theories and the modern concepts, including the role of sucrose, the Stephen's curve, and the ecological plaque hypothesis in caries formation. However, I would always suggest that do not beat around the bush and strictly frame your content based on the marks for the suggested question. The next repeated or major question is on anemia. Questions appear as discuss the etiology, clinical features, and management of pernicious anemia, write a note on anemia in children, thalassemia, write a short note on iron deficiency anemia, write a short note on megaloblastic anemia, describe the diseases of red blood cells. So I have provided the content flowchart for questions on the types of anemia seen in children, including iron deficiency anemia, megaloblastic anemia, pernicious anemia, and thalassemia. So you need to mention their causes, clinical and oral manifestations, laboratory findings, and management with special emphasis on their relevance in pediatric dentistry. So this is a broad classification of anemia by its cause, such as blood loss, decreased red cell production, or increased red cell destruction, or by red blood cell morphology. However, morphologically, it is categorized into microcytic, macrocytic, and normocytic anemia, which helps guide diagnosis and management. So please use these schematic tables appropriately when you answer this question. For iron deficiency anemia specifically, you need to mention that it commonly results from inadequate iron intake, poor absorption, increased physiological demand, or chronic blood loss. You can also add the schematic diagram that illustrates iron metabolism, showing how dietary iron is absorbed, transported by transferrin, stored as ferritin, and recycled for hemoglobin synthesis. For megaloblastic anemia, a very common question that is seen state that it results from deficiencies of vitamin B12 or folic acid that is leading to impaired DNA synthesis and the production of large immature red blood cells. You should also mention its common causes that include like poor dietary intake, malabsorption, increased physiological requirements, and conditions such as pernicious anemia that interfere with the vitamin B12 absorption. So you can build your answer from these take-home points. The next repeated or major question is on hematopoiesis. Describe the process of leukopoiesis with neatly labeled diagram. Describe the process of erythropoiesis with a neatly labeled diagram. So this is a content flow chart that covers hematopoiesis, focusing on erythropoiesis, the formation of red blood cells. So erythropoiesis under the influence of erythropoietin and defects in this process can lead to conditions such as megaloblastic anemia. So understanding these processes is important because they maintain the oxygen transport, immune defense, and also they help in many of or contribute to many of the hematological disorders. So the developmental stages and sites of hematopoiesis is depicted in these figures that are provided here. I have also provided the conditions that cause extramedullary hematopoiesis, such as thalassemia and myelofibrosis. So to provide more weightage to your answer, I would always suggest that it would be good to show the common red blood cell morphological abnormalities and their associated diseases, which are always important clues when you go for hematological diagnosis. So please include all of them appropriately in your answer. So this is a common figure that could definitely explain leukopoiesis. So all blood cells basically they originate from the pluripotent hematopoietic stem cells, which differentiate into erythroid, myeloid, and lymphoid lineages. So leukopoiesis specifically refers to the formation of the white blood cells. So I would suggest that you go through all these diagrams and flowcharts that are given here, and please incorporate them in your answer when leukopoiesis or erythropoiesis, etc. are asked. The next repeated questions are on blood disorders. It comes as write a short note on thrombocytopenia, write a short note on polymorphonuclear neutrophil defects, write a short note on transfusion reactions, significance of hemogram in oral diseases. So this is a content flowchart to approach the answer on thrombocytopenia and neutrophil defects, focusing on their causes, clinical features, laboratory diagnosis, and oral manifestations. So it will be always advisable to highlight the importance of hemogram interpretation in detecting hematological disorders and planning safe dental treatment. So thrombocytopenia, as we are all aware, is highly significant in dentistry because patients are at an increased risk of spontaneous gingival bleeding, petechiae, and prolonged bleeding following dental procedures. So I would suggest to incorporate a flowchart like this with all salient points in managing such cases in dentistry. Careful treatment planning, local hemostatic measures, and very close post-operative monitoring are essential to ensure that safe dental care is provided to these patients. So I would suggest that you can build up your answer from these points that are given here. This is an approach to the question on the significance of hemogram, which is nothing but CBC, complete blood count picture in oral diseases. So a hemogram is an essential investigation in dentistry, as it helps to detect chiefly anemia, infections, bleeding disorders, and hematological malignancies that may present with oral manifestations. So I have listed a few conditions where oral manifestations and CBC are connected. So the CBC also aids in treatment planning by assessing the bleeding risk, immune status, and the patient's overall fitness for dental procedures. The next repeated or major question is on immunity or hypersensitivity. So discuss the types of immunity and add a note on the complement pathway. Write a short note on complement cascade. Delayed hypersensitivity, write a short note on autoimmune disease. So these are brief outliners to the questions asked. So the first one outlines the major components of the immune system, including innate and adaptive immunity. The next depicts the complement activation pathways. The following are the processing delayed hypersensitivity reactions and autoimmune diseases. So your knowledge on the differences between humoral and cell-mediated immunity should be very crystal clear. So understanding these mechanisms is definitely important because they protect the body against infections and also contribute majorly to tissue damage and disease when dysregulated. So kindly build up your answer based on the key points that are provided in the content flow charts. This table depicts the different forms of hypersensitivity. So basically, it classifies hypersensitivity reactions into 4 types based on the immune mechanisms as shown here. So I have added a table on common examples of type 1 hypersensitivity reactions such as allergic rhinitis, asthma, and anaphylaxis, which result from immediate IgE-mediated immune response. So what you also shouldn't miss is the sequence of events in delayed hypersensitivity as shown here on the table on the right-hand side. So in continuation to the previous slide on hypersensitivity, we need to be clear on the mechanism of type 1 hypersensitivity where re-exposure to an allergen triggers IgE-coated mast cells to release inflammatory mediators. So these mediators such as histamine, prostaglandins, and leukotrienes produce the immediate allergic response and subsequent late phase inflammatory reaction. So kindly try and accommodate these schematic representations while answering the question on type 1 hypersensitivity. This representation demonstrates type 2 hypersensitivity where antibodies bind to antigens present on the surface of cells and activate the complement system. So the resulting opsonization promotes phagocytosis and destruction of the target cells, as illustrated here by the antibody-mediated platelet destruction. So please put this representation in the question on type 2 hypersensitivity reaction. Here I summarize the key points on the common dental triggers or the dental and medical concerns and their management in such hypersensitivity situations. So it is prudent that we recognize hypersensitivity reactions in dental practice as common triggers include local anesthetics, antibiotics, latex, or sometimes some few dental materials as well. So prompt identification and management are essential to prevent serious complications such as airway obstruction and anaphylaxis, ensuring patient safety during treatment. So this should definitely be a part of your answer while you answer any hypersensitivity based questions. The next repeated or major question is on salivary disorders, or more commonly as xerostomia. The questions have appeared as thialism and xerostomia. Write a short note on xerostomia, dental management of patient with decreased salivation, discuss saliva as a diagnostic tool in dental diseases, write a short note on sialadenitis, and write a short note on salivary calculi. So thialism or hypersalivation is commonly seen in pregnancy, GERD, certain neurological conditions, and also with certain medications. So try to follow a content flowchart like this while discussing on disorders of the salivary glands, including xerostomia, thialism, sialadenitis, and salivary calculi, along with their causes, clinical features, and management as depicted here. So it would be ideal to also highlight the growing role of saliva as a non-invasive diagnostic tool for detecting oral and systemic diseases. So build up your answer from these key components that are listed here. The next repeated or major question could be on necrosis, degeneration, and repair. The questions have appeared as types of necrosis, define necrosis, discuss in detail about the various types of necrosis, write about gangrene, write a short note on apoptosis, write a short note on cellular degeneration, write a short note on metaplasia, write a short note on pathology, classic calcification. So here I have given an outline on any question that may come on necrosis and apoptosis. As we are aware, the cellular response to a compromised and unhealing injury includes degeneration, necrosis, and apoptosis, along with metaplasia and
সকাল থেকে 3টে ক্লাস করে নিল পুরো অ্যানাটমি রিভিশন করে দিয়েছে আমাদের ওই বেসিক সায়েন্সের অ্যানাটমি রিভিশন শেষ ফিজিওলজি শেষ প্যাথোলজি শেষ একটা মানুষ 3 ঘন্টার ভিতরে 3টা সাবজেক্ট ফুলফুল পড়ে নিতে পারবে সব
also shared here for your viewing. Just emphasize that necrosis is an uncontrolled cell death associated with inflammation, whereas apoptosis is a programmed and regulated process. So basically try to build your answer from the key points that I The next question is on osteomyelitis or pathogenesis of osteomyelitis. What is osteomyelitis? Mention the management of body of body of mandible. Write a short note on Gary's osteomyelitis. Write a short note on osteoradionecrosis. Write about fibrous dysplasia of bone. Describe the fibro-osseous lesions affecting the jaws. So a basic outline or a question on osteomyelitis should include the flowchart that I have shown here on the left-hand side. Common jaw bone lesions including osteomyelitis, osteoradionecrosis, Gary's osteomyelitis, fibrous dysplasia, and other fibro-osseous lesions should also have a structure that I have shown here. You need to explicitly state its etiology, clinical presentation, and radiographic features in each of these conditions. And an accurate diagnosis is paramount in effective treatment planning, which is mandatory when you answer this question. The figure here illustrates the process of fracture healing, which begins with hematoma formation and inflammation, followed by the development of soft callus and then a hard bony callus. So over time, the bone undergoes remodeling, restoring its normal structure and function. So kindly incorporate this figure when you attend a question on organization of bone fractures. The schematic flowchart representation explains, that is over here, explains basically the pathogenesis of osteomyelitis, where bacteria reach the bone, trigger acute inflammation, and lead to the formation of pus and increased intramedullary pressure. So basically the infection can compromise later the blood supply, thereby causing bone necrosis, sequestrum formation, involucrum formation, and may finally progress to chronic osteomyelitis if not treated promptly. So try to incorporate all these salient points that are mentioned in this flowchart while attending an answer on osteomyelitis. So there are other single and less often appeared additional questions that you should definitely refer and prepare individual notes and flowcharts. That definitely I would suggest. Because of time constraints, I have just listed those questions here for your knowledge. Please make a note of them and have them, in your notebook with a sequential flowchart having, all the respective aspects to each of these questions. So the questions which have come maybe once or twice among all these papers that I've seen, less common. Write a short note on biopsy. Write a short note on cytokines. Write a short note on granulomatous inflammation. Histologic picture of granuloma. Write a short note on free radicals. Write a detail on tumors, benign and malignant and neoplasm, and add a note on the TNM staging. Discuss the nature and the pathogenesis of amyloidosis and sarcoidosis. Discuss the pathogenesis of edema and causes of edema, and write a short note on hemochromatosis. Please make a note of all of this and make your flowchart as convenient. So I have also listed here the references that you may cite while attending questions on pathology in the basic science paper. You may try to memorize at least 2 or 3 of them so that, it just gives an impression to the examiner that you are definitely well read on this subject. Well, to conclude, effective learning requires a structured study schedule, regular revision, concise note making, and maintaining good physical as well as mental health. So I would suggest that you take short breaks and stay consistent in your preparation because it greatly improves your understanding, retention, as well as your overall academic performance. So stay calm and keep revising, and I'm sure that success will be yours. Thank you for your kind attention.
Thank you, sir. Thank you for that enriching session.
Thank you so much.
I guess there are a few questions. Most of it has been answered.
Yes, ma'am, I've answered, ma'am.
Yeah. Is there any other thing that you need to answer? Have you gone through the questions? I think that's done. Any more questions from anybody?
No, ma'am, no other questions.
Okay.
Thank you so much, ma'am, for giving me this opportunity. I'm really, really happy to share knowledge in such a platform. I hope I have covered almost all the topics that have appeared for pathology. So kindly go through the flowcharts and do the needful. All the best to all the first year postgraduates.
Thank you,
you.
Dr. Atul. That was a well-researched question paper session, I know. Thank you. Thanks a lot.
Thank you, ma'am.
Thank you, sir.
Thank you.
Kindly accept this certificate as a token of gratitude and appreciation for your valuable presence and insightful session. Thank you, sir.
Thank you so much. Thank you. Thank you.
Now, it's a time for lunch break. Kindly reassemble by 2 p.m. for afternoon scientific session. Thank you.
Thank you.